colleagues assigned, Transcorp staff assigned to this room, maybe to make sure that when you people are on break, this room is kept safe. Because unfortunately, we are still having that issue. We have ongoing investigation on that. Some colleagues lose their computer here. While they were on break, someone come in. He was not a staff of the hotel. He was not concerned by the meeting, and he went out with a computer and one bag. So please, make sure that you secure your items. This is the first point. The second point, avoid when you are moving around, during your movement avoid public transport, please. Because one of the main security issues we have here in Nigeria, including Abuja, is kidnapping. Kidnapping for ransom. Okay? We had some experience even with UN staff. And these people, they don't joke. If they kidnap you, they will ask for millions of naira. And if the money is not paid, they can even kill. We have seen that here. So be very, very careful, please, when you are moving around. Our advice is to rely on hotel reception so that they can call a taxi for you. Or I don't know if you have Ball in your phone, it's an application to order a taxi, but I will highly recommend to rely on the hotel reception. They know the taxis, they can call one for you. He will take you where you are going and bring you back safely. It's very important. And the last point is how to manage your money, your ATM card. Avoid using it anywhere because it can easily be either scanned or copied and used to purchase things abroad. We have seen that also. Our advice, if you have cash, then it will be better to pay, to change your cash in naira at the reception and pay directly without using your ATM card. These are the 3 points for you. I know I don't want to give you the overall security briefing for Abuja because I know you are here just for some few days, so I will not disturb you with that. But please, these are the 3 key points for your own security while you are here. If you have any question, any special concern, I'm listening to you. But first of all, I will ask you to take my phone number and feel free to call at any time for any issue. 24/7 we will respond. Please. +234 90 627 40 617. My name is Parfait, Field Security Officer, WHO Nigeria. Thank you.
Thank you very much. Thank you. We will also put the number along the line on the screen for all of us to have. And colleagues online, are there any additional information or comments? I did not see anybody in the hall raising his hand. In the absence of any, I will quickly first go to the agenda. Can you project the agenda? After the agenda, we'll do self-introductions. After that, we'll have the meeting objectives and expected outcomes, which will be presented by the PEP coordinator, either Dr. Dutabe or maybe Dr. Akif, as the case may be. Then we will have the objectives of the lecture basin, which will be presented by the project manager, Leopold. And then I will present the overview of polio situation in the lecture basin. Then we'll go for a break. The first presentation will be by Nigeria. We have received the presentation. We thank the Nigerian team. That will be followed by Niger, then Chad. And after each presentations, we will have discussions. Then we break for lunch. And finally, we will continue after lunch with Cameroon and Central Africa. Then we will do a wrap-up. I did not see the agenda. Okay, thank you. This is the agenda. Like I said, I don't know whether online have, yes. Whether online, this is the first segment of today. So this is a 2-day meeting. The first segment is the first about what I have just said. Meeting objectives of LCB, overview of polio situation, and then we break for lunch. In the absence of any queries, I would like to ask individuals to start introducing themselves. I'll start with Dr. Wade.
Good morning, colleagues. Good morning, everybody. I am Dr. Patricia Tanifu. I am the Program Director for Global Immunizations Division with CDC in Nigeria. But I was just informed that I am invited to this meeting as a member of the Polio Oversight Board. So my colleagues in Nigeria, sorry, I crossed the line today.
Thank you.
Thanks, Sadiq. Oh, God, please don't zoom on my face. I'm Chris Maher. I'm a member of the Oversight Committee.
Cordo.
Moi, c'est Yamego Charlemagne. Je fais partie de l'équipe de coordination des pays du bassin du lac Tchad, point focal surveillance.
Bonjour, moi c'est Aboubakar Sissé. Hello, I'm Aboubakar Sissé, Team LCB.
Yes, bonjour, moi c'est Gorgui Batouré, data analyst avec DIM en appui au LCB.
Good morning, everyone. Good morning, everyone. My name is Iya Saidou Konde, member of the Lake Chad Basin Coordination Team.
Bonjour tout le monde, moi c'est Mahmoud Abdoulaye, je suis consultant, je viens de rejoindre le groupe. Je travaille dans le cadre des populations spéciales dans l'équipe.
Good morning, I'm Fabien Diomande, Deputy GPEI Coordinator for Nigeria.
Bonjour, Adèle Dalé, qui est de la coordination du bassin de lac Tchad.
Good morning, this is Dr. Al-Umra Omar. My face, okay, yeah, because I can see, yeah. Okay. Good morning, Dr. Al-Umra Omar. I'm a Deputy GPEI for from UNICEF for Nigeria. Thank you.
Good morning. My name is Dr. Audu Musa Idowu. I'm the Deputy Incident Manager, Polios in Nigeria. Thank you.
Good morning. My name is Usman Ganabel Kadir, Incident Manager, Nigerian Polio EOC.
Bonjour à tout le monde, je suis Adamou, c'est moi GPEI coordinateur Nigeria.
Merci, merci beaucoup à chanter. Good morning, my name is Dr. Khalid Abdurrahim. I'm supporting Lake Chad Task Team, the focal point for SIA and mobile population.
Good morning, I'm Leopold Donfak Basso, Project Manager LCB Team.
Good morning. My name is Pascal Mkanda. I work as a GPS Senior Advisor for the POE program. Thank you.
Good morning, everyone. My name is Katerina. I'm advocacy focal point for LCB from WHO Afro. Thank you so much.
Thank you. Can we go back online so that my name is Sadiq Umar. I'm the lecture coordinator. Jesu Sadiq. Yes. I'm going to have to improve my French. Please, can we go back online?
We start for who?
We start from you, sir.
That's good. Ndutabe Mujirom, I have been appointed like RRT coordinator for one who is in the room right now, but I am at interim for the PEP coordinator for the African region. And sorry to not be with you. Probably when I will make my statement, I will tell you why I cannot be with you right now. And thank you to be really for this meeting. Back to you, Sadiq.
Thank you. Girma.
Bonjour à tous. My name is Tadei. I work with UNICEF at headquarters as a senior program manager, and I'm part of the Oversight Committee. Sorry I couldn't be with you, and my camera doesn't seem to be working, but I hope to be with you very soon and looking forward to the discussions. Thanks.
Thank you. Lara. Put your camera, Lara.
There we go.
Yeah.
Good morning, everyone, or good night from Seattle. My name is Lara Page. I am on the Lake Chad Advisory Committee. I'm with the Gates Foundation. I'm a program officer on our outbreaks team.
Thank you. Bambe from Chad.
Merci beaucoup. C'est Bambe Lampoint. Je suis maintenant manager.
Hello. Are you muted, Bambe from Chad? Okay, search. Search. Chat has having problem. Let's go to Desiree, Cameroon. Desiree. Okay, go ahead. Thank you. While we are trying to get chat back, let's just go to Desiree. Dr. Desiree.
Bonjour à tous. My name is Desiree Toboe, a GPI coordinator from Cameroon. Thank you.
Thank you. You didn't put your camera. Kasil, please, online colleagues, when you are introducing, put on your camera. Kasil.
Good morning, everyone. My name is Dr. Claude Kassil Manche. I'm the polio specialist based in Dakar, and I'm attending this meeting on behalf of West and Central African region as a focal point. Thank you.
Thank you very much. Sosu, Dr. Sosu from Chad.
Good morning, everyone. My name is Sosu Aristide. I'm the team lead polio for Chad and also GPI coordinator acting. Over to you. Thank you.
Thank you. Guy Rogers. Guy Roger. This is Cameroonian. You read it like that. I read it in English. Rogers Kamga.
Oui, il faut fermer.
Kamga. Okay, Bambe, are you online? Dr. Bambe from chat. Is it okay now? You can come online. We didn't get him also. Lillian, can you introduce yourself with your camera? Lillian.
Yes, good morning, everyone. I'm putting my camera in a few seconds. My name is Lilian Kudibali, and I'm a program manager working at Solina, Nigeria. Thank you. I'm putting the camera in a few seconds, taking time.
Thank you very much. Adebayo. You are muted, Adebayo. Oh, Ario is here now. No, sorry. Ario is here. Is Ario? Why are you confusing me? I can't see this now very clear. Monitor what? Eh?
Stream monitor.
Stream monitor. Sorry, okay. They are part of us. They are supporting us with the ICT. Andreas? Andre? Berete?
Yeah, good morning, everyone. My name is Ansman Berete. I recently joined the team as a technical officer of response and currently providing technical support to Chad country office. Thank you. Over.
Thank you. We still have Dr. Bambe.
Oui, vous me recevez maintenant?
Yes, oui.
Oui, oui, c'est Dr. Bambé, l'incident manager polio du Tchad. Merci beaucoup.
Merci. Is there anybody that we miss out? Ah, Dr. Akif. Yes, I'm standing in front of you.
Thank you. Akif Saacholu from the regional office and also the part of the Oversight Committee. Thank you.
Okay, thank you. So we have our members of the Oversight, we have them here. So I think we can now go ahead and present the objectives, the meeting objectives, and the expected outcomes. Meeting objectives and expected outcome. Can you put it online, please? Doctor.
It is 2 slides actually. It's there? Okay, good.
Just give the IT a minute to check it online.
Okay. Good morning all again here in the meeting room and online. So this is on behalf of Dr. Nutabe, PEP coordinator at the regional office, WHO Afro. So Dr. Nutabe couldn't make it here because of the back-to-back meetings and several commitments. So I am just doing this presentation on his behalf. So we have an overall objective. This is a 2-day meeting. As you know, the first day is the task team meeting and with the countries, and the second day is the task team plus oversight committee, so that there would be discussions on the outcomes of today and the other, the issues, the way forward, and support mechanisms in preparations to the upcoming round, as well as to the overall polio activities for the rest of the year, even beyond. So the overall objective is to review and discuss openly, frankly, results of the round 1, as we all know, in the all lecture-based countries, and that is the first day. Then we go to to the second day where we have the oversight committee to look into those challenges, opportunities, support needs that actually arise from day one, and the mechanism in preparation to round two NIDs, and as I said, also the beyond polio, all polio eradication activities. So let's go to specific objectives. I'm not going to go through each details, but the headlines, you would have this, of course, the slides disseminated. So conduct a comprehensive evaluation of each country's round one performance. So especially with a focus on persistent challenges. There are challenges we keep talking, but we couldn't really get through, any breakthrough in terms of resolving those challenges, addressing them. And the quick wins. What are the solutions? Immediate implementation ahead. So we may focus on the long term, but let's focus for the round two now. Review the lecture task team's plan of action. Of course, one day is not enough to review the whole plan of action. It's a comprehensive plan, but to look at what are the strengths, pinpoint gaps, and areas for improvement. And roles and responsibilities, actually, especially in terms of coordination, management, and oversight by the task team with the countries within the task team. 3, assess the implementation of cross-border activities. We keep speaking of cross-border coordination, cross-border collaboration, but where are we with that? Are we making progress really on the ground? And what are the solutions if we are not, or there are some issues now arising from the round one? Analyze the end-to-end funds flow. That's important. We used to have this funds deployment delays. Are we still continuing to have it? We have now SOP at the regional level. All funds should be at the central level 5 weeks prior to campaign. And of course, now we are tracking even down to the lowest admin level. Are we getting there or not? Because sometimes one of the issues, other than the operational constraints, is delay in deployment of funds. So where are we with that? We have been doing this. Dr. Sadiq is also, and some of also other colleagues in the task team participating in our daily briefings. We are tracking these ones. Apparently we have some issues, so we want to know what are they, why they are. Review a harmonized strategy and implementation plan. Strengthen partnership and coordination mechanisms. That number 6, you could see that it goes all along with the number 2 also. But this time, it also involves key stakeholders. So it is not only within the task team with the countries, but all the other key stakeholders. So it is actually complementing number 2 in a way, but beyond. Align on the operational framework and priorities for the ongoing partnership. So that is also linked to number 6, 7. So some of those things are interlinked as we go along, and once we cover one, we may cover the others in a way. Next slide, please. So this is, of course, the last slide as part of the, the presentation. What we expect. So we expect improved country-level performance insights. We expect enhanced task team effectiveness. We expect optimized cross-border coordination and delivery, and streamlined funding flows, unified approach to synchronize NIDs, and the last, not the least, clarified partnership framework within the LCB. Actually, when we say advisory, this is the oversight committee. So what is the ways and means of interaction and working between the task team, of course within the task team with the countries, and the oversight committee. So we need to have clear identification, success, challenges, list of quick wins for round 2. So let's focus on that, because we know that next time when we will have another opportunity to have such a, the wide response, we are not sure, because of the reasons that you all know. So this is a really window of opportunity after the round 1 to do round 2 based on the performance of round 1, even improved and a very high quality campaign. And are we ready? If we are not, why and when will we be ready? So we need to rush, but we don't need to rush if we are not ready. So are we ready? We have been discussing this individually. Then we see there is literally, hypothetically, 2 weeks to go to the next round. Are we there? Do we need more time, or we feel comfortable to go in 2 weeks' time? Of course, the team effectiveness, I don't need to go clear roles, responsibilities, accountability. This oversight and accountability, as you know, we keep talking about it since years, so long. So in concrete terms, we are really expecting some outcome of this meeting, where we are and what are the mechanisms of accountability. And cross-border coordination, there are of course some initiatives that we would hear, how we have been doing, are we doing well? As we know, the importance of the cross-border, the transmission and circulation, that is ongoing, especially in neighboring countries where we have a porous border and where we have detections, ongoing detections. So funding, of course, we all say there should be money. And what are the other possibilities of funding? That is, I think we need to look in a way, disbursements, transparency, and where we are, what we are doing in terms of deployment of funds in time, not to the country, but within the country to the lowest level, the processes. And then regionally agreed, harmonized strategy, operational plan, alignment of stakeholders, efficiency. When we say efficiency, it's also linked to funding. So when we are talking about the efficiencies, it is also the cost efficiencies. So are we really utilizing the funds that we have in the right way, in the efficient way we are, or it is just a kind of template that we are putting, and then spending the money, looking at the expenditures, but where are we with the efficiencies? So the effectiveness, both the cost effectiveness as well as the outcome, and in the long run, of course, the impact. So partnership, we need to understand what is our collaboration modalities with the task team and the oversight committee, roles, responsibilities, communication channel, and how we are going to communicate, how often we need meetings like this one. Are we going to have a meeting after round 2? When? Are we going to have more kind of impact measurement of 2 rounds in terms of the where we stand, and what would be our actual expected, in a way, not only output, but the outcome of these 2 rounds. Are we making some impact? And of course, governance, policy support, and the most important thing we just discussed, and Dr. Sadiq stepped in while we were having our daily briefing. There is a lot of questions about the campaign dates. So do we have the round 1? Yes, we did. We completed all over the place. Are we going to have the round 2? And of course, then the meeting date for a post-campaign after 2 rounds, as I said. But the critical thing is, in this meeting, we need to nail down what are the days. Of course, we always have flexibility, but the longer it takes, the higher the risk of, the polio immunity wanes over time. So that's why we want to do it within SOPs, the 4 weeks time. If you go 5 weeks, 6 weeks, 7 weeks, 8 weeks. We have countries in our region for all sorts of reasons. We had the campaign in February and the second round in May. So you see the interval, and then we keep detecting the virus there, including orphans. So really, we need to nail down the days, and we need to also, not I wouldn't say confirm, but at least indicative dates for a post-campaign meeting with governments, of course, like this one, and with the oversight committee. Whether it is looking at now the overall situation, whether it is the mid-June, end June, early July, so we need to come up with a really, this time around, it is a quick meeting, because of the preparation for round 2, but that time we can have a more time to really get into the discuss deep dive and see where we stand. So if there is any questions or points for clarification, please feel free. Thank you so much.
Thank you very much. I will thank you, Dr. Akif, for this presentation, but please allow me to ask Leopold to quickly summarize the slides in French. Objectives and expected outcomes in French.
Thank you, Cordo. Un résumé de la présentation qui a été faite par le docteur Akif. Notamment, on va commencer avec le premier point, ce sont sur les objectifs. Le premier objectif est de conduire une évaluation des pays du premier rang de la campagne dans les 5 pays du bassin du lac Tchad, notamment d'évaluer les performances. Le deuxième objectif, quant à lui, il vise à évaluer la mise en œuvre des activités transfrontalières. Le deuxième objectif était la revue de plan d'action polio du bassin du lac Tchad. Le troisième, évaluer la mise en œuvre des activités transfrontalières. Le quatrième, c'est d'analyser le flux financier pour les opérations. Le cinquième, c'est de faire une revue à harmoniser les stratégies. Le sixième, c'est de renforcer le partenariat et la coordination, le mécanisme de partenariat de coordination. Et le septième, c'est de pouvoir aligner les opérations sur les priorités et les partenariats. Donc, si on passe au résultat attendu de notre rencontre. La première attente, c'est de pouvoir améliorer les informations sur les performances au niveau des... Sorry, turn back again to that point. Si pour aller aux attentes, OK. Is that first one is c'est d'améliorer l'efficacité de la task team, je pense. Le deuxième, c'est de pouvoir renforcer l'effectivité des activités de la task team. Le troisième, c'est de pouvoir optimiser la coordination transfrontalière et la mise en œuvre des activités. Le quatrième, c'est de pouvoir renforcer le flux financier. Le cinquième, c'est de pouvoir synchroniser la campagne et avoir une approche commune pour pouvoir synchroniser la campagne, notamment le deuxième passage. Et le sixième, c'est de clarifier les partenariats dans les pays avec le comité, avec ce comité LCB. Dans ça, over. Nous allons faire une traduction de ces diapositives qui seront partagées par la suite.
Thank you very much. We apologize to our French colleagues who will translate the slide, who will share it. We had problem with the translators. We were not able to get them on board. So now it's open for questions. Can you go back online to see the participants? Is there anybody here who wanted to raise an observation or online without seeing any name there? I will now ask for the second presentation to come online. And that is the objectives of lecture. Oh, you have a hand. The advisory want to advise us.
All right. So thank you very much for the presentation and this. Maybe I'm jumping the gun of things area, but There's certain things which I think from that slide for me which are bigger concern than other things. The first thing is that I hope this is 2025. And we're still talking about issues of funds flow reaching implementation. So I wonder, really at all levels, how seriously we are with this program. We should be talking about the funds reaching implementation level at this stage in the program. And when you were talking about then a unified approach to synchronize round 2, I don't have the answer now, but how sure are we going to have really a good quality round if we're still having all these issues? And the round is between, I think the round is supposed to be planned for end of this month. When you have got so many fundamental issues which need to be sorted out. So it's just a very big a concern to me, because it looks like we've got so much work to do before even the second round itself. So it's just a concern. It doesn't have to be answered now, but maybe later during the presentations. Thank you.
Thank you very much. I will ask Ia to translate the comments of Dr. Pascal.
Merci. Dr. Pascal, qui est membre du comité conseil de polio, sa question c'était vraiment concernant les slides présentés. Il a dit qu'il y a des points un peu plus inquiétants que d'autres, notamment la question concernant l'envoi des fonds du niveau national vers le niveau opérationnel. Il se demande, nous sommes vraiment en 2025 et jusqu'à présent, nous sommes confrontés à ce genre de problèmes dans nos campagnes. Et vu le temps qui nous reste, est-ce qu'on est vraiment sûr que nous pourrons, avec ces challenges qui se posent, améliorer ces difficultés avant les prochaines campagnes? Parce que, comme nous le savons, il y a d'autres pays qui vont commencer bientôt dans 2 semaines, certains moins de 3 semaines. Donc, il est vraiment inquiet. Peut-être on aura plus de temps pour en parler. Merci.
Thank you. Can you go back still? Let me see online if there is no any raised hand on the online.
I cannot raise my hand just because I cannot see where I have to raise my hand. But
Go ahead, sir.
let me just emphasize on what Dr. Mkanda Pascal said. And countries will present must be true. Let me really, give the background of this meeting. Remember, when we had this first meeting in Abuja in February, I remember very well, we asked our people vaccine management, but also the team who is handling the fund to bring all those resources in the countries the 15th of March. That means 5-0 before we are starting implementing campaigns. That means they have more than 1 month really to, send all those resources in the remote area. So we must be comfortable. And I don't understand very well the concern coming from Pascal, who is the member of Oversight Committee. Country must really tell us, frankly, during their presentation, what was wrong. I am talking about countries, but also agencies, mainly WHO and UNICEF. I will call, if you don't mind, Dr. Sadiq Kumar, I will call our financial people. They made a kind of analysis on daily basis to know deeply inside each agency where we have the bottlenecks. So all those things you have to put together to know what solution you have to propose to countries. That's the first one. The second one, if we had 50 days receiving all resources, and we'll see with the presentation, which will be done very soon, the situation is not really very good. How we can be sure that in 2 weeks, we'll make a very good synchronization, meaning probably today or tomorrow, we have a very strong decision to be taken. For the Lake Chad Basin Task Team, if you put in place Lake Chad Basin Task Team, meaning, and the main goal is the synchronization. The main goal is not to allow each country implementing, I can say inside their country, the campaign alone. No, it's the synchronization. So let's talk about synchronization. So let me make this clarification and emphasize on what Pascal said. Probably it will help for discussion. So back to you, Sadiq.
Thank you very much. Can you just summarize it in French for our colleagues? Dr. Nutabe, can you please make a summary in French? Hello, Dr. Nutabe. Okay, we lost him online. I will ask you again to make a summary of what Dr. Nutabe said.
Dr. Nutabe juste insistait sur le point toujours concernant l'envoi des fonds. Il a dit que c'est vraiment un point critique. Pour rappel, quand nous étions là au mois de février, il avait pris un engagement que tous les pays allaient recevoir les fonds au plus tard le 15, c'est-à-dire plus d'un mois. Ils devraient avoir plus de 45 jours pour envoyer ces fonds-là vers le niveau opérationnel. Et cela a été fait. Tous les pays ont reçu les fonds avant cette date ou à cette date. Mais malheureusement, nous sommes restés toujours confrontés à cette difficulté. On a eu des pays qui ont envoyé des fonds en retard. Certains districts ont été obligés de reporter les campagnes. Donc, au vu de tout cela, une décision importante doit être prise pour améliorer cette condition. Autre chose qu'il a mentionné est que le but principal, l'objectif principal de la coordination du bassin du lac Tchad reste et demeure la synchronisation des campagnes dans les 5 pays. Donc, nous devons vraiment insister sur cela au cours de ces 2 jours de discussion. Merci.
Thank you. We will take Andreas and then we will move on. Andrea, you are online. Go ahead and mute and say your comments.
Yeah, thank you so much, for giving me the floor. I'm Andreas from Cameroon. Thank you for the presentation. Just wondering, are they keeping the next campaign round date flexible? My comment, because Cameroon's minister already signed a communique in that light, engaging stakeholders and the community on the date that we planned in the last meeting. And if it's flexible, then it's going to be a great challenge for us. Thank you so much. Over to
you. Andrea, please say it also in French, since you are bilingual.
Ok, merci Kodo. En fait, j'ai demandé juste après la présentation des interventions si la date du deuxième tour du campagne est modifiable par les pays. Et je note quand même qu'au Cameroun, le ministre de la Santé avait signé une note pour engager la population et les leaders en annonçant la date que nous avons fixée dans la dernière réunion à Abuja. Et donc, si cette date est flexible, ça sera vraiment difficile pour le pays si on doit changer cette date. Merci à vous.
Thank you very much. I think all these are comments. We will take note. While we go into the detailed presentations, we will deal with them accordingly. Can we have the next presentation? Please, there is an adjustment in the agenda. Nigeria has another line of meetings and activities, so we will shift their presentation to come before the tea break. So once the Lake Chad Basin has presented an overview We will now call on the Nigerian team to make the presentation, and then we go for break. Thank you.
Thank you, Kodo.
What about the break for those online?
Thank you, Kodo. We go with the LCBC objectives. Yes, the version in English. I think I will present in French. The slides are in English. I will present in French. Maybe we can gain times. Yes. OK. Diapo, allons-y. Donc, pour ce qui est des objectifs de la task team, il faut dire que le but, c'est d'interrompre la circulation du poliovirus dans le bassin du lac Tchad d'ici la fin de l'année 2025. Et pour ce faire, on va avoir à renforcer la coordination et les stratégies d'immunisation, de vaccination, et se mettre en place un système de vaccination, de surveillance robuste pour pouvoir capter tous les cas, et également couvrir les zones à haut risque et les zones avec des populations qui sont peu desservies, peu couvertes. Comme objectif, nous avons 5. Le premier objectif vise à renforcer renforcer la population et le leadership, et également les partenaires. Notamment le deuxième, il reste à établir et à renforcer une coordination entre les différents pays. Et le troisième objectif, c'est de renforcer au niveau des frontières la surveillance et également la cartographie des populations à haut risque. Et le quatrième objectif reste à optimiser la vaccination au niveau des frontières, les stratégies de vaccination au niveau des frontières, et également synchroniser la mise en œuvre. Et le cinquième consiste de façon conjointe à renforcer l'engagement communautaire et le plaidoyer, avec un accent sur les populations qui vivent le long des frontières et les populations mobiles et à haut risque. Les priorités, au niveau du bassin du lac Tchad, nous avons 10 priorités. C'est juste un rappel. Il faut dire que les premières priorités vont porter sur la coordination. Notamment, il s'agit de renforcer l'appropriation et le leadership des gouvernements. La deuxième priorité pour 2025, c'est de promouvoir un plaidoyer de haut niveau et la communication. Le troisième, c'est de pouvoir renforcer les mécanismes de coordination au niveau transfrontalier. La quatrième priorité fait référence à la surveillance et consiste à pouvoir renforcer la surveillance dans les zones à haut risque. La cinquième, qui porte sur les AVS notamment, c'est de pouvoir améliorer la microplanification et le tracking des populations spéciales. La sixième des priorités porte sur la synchronisation des activités au niveau transfrontalier. La septième sur l'extension de l'utilisation des applications mobiles pour la vaccination, l'utilisation des équipes mobiles pour la vaccination. La huitième des priorités porte sur le renforcement de la collecte de données, de l'analyse. La neuvième sur les innovations dans les zones à sécurité compromises et les zones où il y a des difficultés pour atteindre les enfants. Et la dixième des priorités, c'est l'intégration de la polio dans toutes les autres activités de santé. Voilà un peu de façon à ramasser les 10 priorités que nous avons dans le LCB. Merci.
Thank you. This is the summary of the priority areas, which are 10, as well as the objectives. Overall, the objectives is on border and special mobile populations. That is what it is. So are there any comments from our colleagues in the room as well as online? Can you go back online, please? Let me see whether there are people with raised hands. For people online, you have a golden visa. You just start talking, we will stop. Even if I don't see you raise your hand. Go back to the yes, Pascal.
Sorry for being a very big mouth all the time. On these objectives of the lectured basic task team, we have had these objectives of the lectured based task team before. I think it's not my first time I'm seeing that slide. Since existence of the lectured based in task team, I was expecting in this presentation that what have been the challenges you have been facing as lectured based task team. What are the things which you think could be done better, either to support the lectured based team, or which things you feel are completely irrelevant or beyond the lectured based team? So I hope, I don't know, as I said, I'm asking things which are maybe coming later. It's coming later, babe? Or tomorrow, sorry. I'm very odd. So I hear this will be discussed tomorrow, but I was just surprised that I've seen those slides before. I didn't really see anything of what have been experienced since we established you. Thank you.
Thank you very much. You know, the next presentation, the immediate next presentation will address that. There are no hands online. I don't know here, you need to just say what Pascal in a summary. Don't repeat 100%.
Thank you. Donc, Dr. Pascal disait que ces priorités, objectifs et priorités du bassin du lac Tchad, la coordination du bassin du lac Tchad, on les a déjà vus, ce n'est pas la première fois. Il s'attendait à plus voir, après la présentation de ces objectifs et priorités, quels sont les défis et comment on pourrait améliorer, faire les choses autrement. Mais je crois, entre-temps, Dr. Sadiq lui a dit que cela sera abordé soit à la fin de la journée ou demain.
Thank you very much. We now Dr. Fabian.
Thank you. Just to understand a little bit better, I guess these are operational priorities, right? And then, is there any area, maybe geography or countries or sub-countries, where, you know, okay, let me say differently, how those priorities are distributed in the other in the whole geography in the Lake Chad? Do you need more integration in maybe one country, or do you want to do integration everywhere? Do you have more high risk or underserved population somewhere, and you want to? How do you distribute your priorities, you know, across the geography in that area, or those priorities are the same everywhere? Or there is a country or sub-country somewhere you want to do more innovative approaches or more synchronization or integration, etc.?
Thank you very much. I will respond, then here you will summarize both the response and the question. The priorities is all across. Our own tax is 5 countries: Nigeria, Niger, Central African Republic, Chad, and Cameroon. So whatever that happens in polio vaccination along the international borders or settlements around the international borders, and special and migrant population, especially refugees, IDPs, security compromised areas, as well as any other population that is at high risk, we take it up. Our primary function is to bring this package along these geographies that I said, the borders of this country, addressing these special and mobile populations that we have. Those that are at the border, such as border districts, those that are migrants, either migrant fishermen or migrant herdsmen, and so on. and other occupational migrants, seasonal occupational migrants, such as farmers that move from one point to another to look for livelihood. So the security compromise area are both within or along the border. It could be within the country. The same thing about displaced persons could be within or along the border. But our aim is to have a plan that works for all them, so that as these migrants and special population are transiting from one country into the next neighbor, we know where they are moving and how we can take to them the second, third, or fourth dose of whatever we have. And we have a multi-pronged approach in that for immunization. Apart from the supplemental, we have in-between round activities to strengthen routine immunization-related activities to close the remaining immunity gaps. Similarly, for vaccine preventable diseases, it's not only polio that we'll be dealing with in that area. I think with time, as we go into the presentations, it will be more clearer. Doctor.
Merci. Donc, la question du docteur Fabien, c'était sur, concernant ces objectifs opérationnels, comment la coordination du bassin du lac Tchad distribue ses objectifs et ses priorités dans ces 5 pays. Est-ce que, par exemple, pays A a besoin de plus d'intégration des activités que pays B, ou est-ce qu'il y a des populations à haut risque dans un pays X plus que l'autre pays, et quand c'est comme ça, comment est-ce que ces objectifs opérationnels sont adaptés en fonction de ces contextes? Alors, la réponse de Dr Sadiq est que il a d'abord rappelé que l'objectif, le focus ou le point essentiel de la coordination du bassin du lac Tchad, c'est centré autour des activités qui se passent le long des frontières des 5 pays. Nous avons 5 pays que vous connaissez tous, savoir le Tchad, le Cameroun, la RCA, Niger et Nigeria. Et parmi ces activités prioritaires, il a parlé de quand, par exemple, nous avons un problème sécuritaire le long des frontières. On essaie de gérer le mieux que nous pouvons. Et comment vacciner les enfants autour des 2 frontières, comment atteindre les populations à haut risque, comment intégrer les activités des routines dans la vaccination contre la polio, et comment aussi faire des activités entre des tours. Par exemple, quand vous avez une zone à sécurité et qui est faiblement vaccinée au cours d'une campagne, avant la prochaine campagne, les dispositions sont prises. Donc, c'est un paquet dans lequel nous puisons en fonction des réalités et des contextes. À vous, Dr. Sadiq.
Thank you. I think we move to the next, please. The next presentation is an overview of the Lake Chad Basin. What we will do is, for each slide, I will ask Leopold to translate quickly so that we move forward. And next presentation. Thank you. Next slide. These are the Lake Chad Basin area, Fabian. You can see the areas that are marked. These are the 5 countries there and the respective districts that are on the border.
Thank you. Sur cette diapositive, nous pouvons voir les 5 pays du bassin du lac Tchad, et à l'autre droite dans le petit tableau, on peut voir le nombre de districts qui sont au niveau de la frontière. Over.
Next slide. These are the trend of viruses in the past 12 months. If you are looking at this slide from right to the left, you see the trend to understand whether there is a decreasing trend or the number of viruses is reducing, both in terms of number as well as the geography. The summary is that there is just minimal reduction. Of course, we know in the last 12 months we have had 209 viruses, which by this last slide on the left, we have 73. This is not where it will take us to the objective of interrupting transmission. This reduction, while yes, there is reduction, but it is with all respect to all of us and our government and our colleagues, we will not say it is as desired. And therefore, there is a lot of work to be done. The same way, if you look at it, that in the last 6 months, in the left side of the table, we are supposed to have 5 countries now. So the total number of countries, why it is 12 months ago it was 4, except Central African Republic, now we have all the 5 countries having a virus, including the Central African Republic.
Sur cette diapositive, nous pouvons voir les tendances de détection des cas de polio variant au niveau du bassin du lac Tchad. Et nous pouvons voir que la tendance, elle va vers la baisse. On peut voir qu'en 2000...
Why? You are just...
Nous pouvons voir qu'au cours des 12 derniers mois, nous avons 209 poliovirus variants. Et si nous regardons à notre droite, à notre gauche, au cours des 6 derniers mois, nous n'avons que 73. Mais il faut dire que si on regarde le nombre de pays dans lesquels ils ont été détectés, il y a 12 mois, nous avions 4 pays. Mais au cours des 6 derniers mois, nous en avions 5. Y compris la RCA, qui tout récemment a eu un nouveau poliovirus variant. Il faut dire que cette tendance n'est pas suffisante pour pouvoir interrompre la circulation d'ici la fin d'année.
Have you ever seen interpreter pushing my slides? I'm the one to run the slide, my friend. So let's go to the next slide. Next slide. Oh, this one. Okay, thank you. And if we still look at the performance just by quarter, we reduce the timeline by quarter and by geography, we will see what we are saying is that in Q3 of 2024, while we had 99 cases are spread across 54 districts in 4 countries with the exception of Central African Republic, in the same trajectory, if you look at it, just explaining the other slide further to see it, that in Q1 of 2025, as it is now, we have 43. Yes, there is about 50% reduction, but like I said, there is also an expansion. Instead of 4 countries, we now have all the countries in the Lake Chad Basin having the virus. So in terms of, if you look at the map, you will see that the areas that have the viruses are still in predominantly where we used to know them, in the northwestern part and northeastern part of Nigeria, and in the borders of Nigeria with Chad, as well as borders of Chad along the side of Central African Republic. But we have the viruses in all. The dots are not fully represented there, and the table below will show you the districts in the same way. Look at Chad. Chad had 11 districts in that quarter of Q3 of 2024, and it still has 11 districts in Q1 of 2025. In terms of Niger, there is significant reduction. In terms of Nigeria, from 31 districts, they have reduced it to 15 districts, and it is reflected on the graph that is on the map that is on the left side of the slide. Similarly, in Cameroon, they had 3 districts in Q3 of 2024. Now they are having 2. So I think, yes, absolute numbers reduce. Yes, geographical areas reduce, but it's not significant, more especially because of the fact that we are having a lot of orphan viruses in the 3 countries such as Nigeria, Niger, and Chad. So we have issues with immunity. We have issues also with surveillance. It is not optimal.
Sur cette diapositive, nous pouvons voir la répartition au cours des trimestres, notamment nous pouvons voir au niveau du 3e trimestre 2024, nous avons 54 districts et 90 virus ont été isolés, dans les 99 poliovirus variants. Et si nous comparons avec le premier trimestre de l'année 2025, là nous avions 18 districts et 43 poliovirus variants confinés. Et on peut voir que peut-être la tendance globale est vers la baisse, mais il faut quand même se rappeler que passer de 4 à 5. Et également, on voit que la répartition des cas reste pratiquement avec la même tendance au cours du troisième trimestre 2024 que le premier trimestre 2025. Et si nous regardons le tableau en bas et à gauche, nous pouvons voir qu'au niveau du Tchad, par exemple, le nombre de districts dans lesquels on a isolé le virus en 2024, le troisième trimestre était de 11, et au premier trimestre 2025, nous avons toujours 11. Si on regarde également au niveau du Cameroun, nous en avions 3 districts au niveau du troisième trimestre 2024. Et là, nous avons maintenant un district au niveau du premier trimestre 2025. Donc, les tendances sont peut-être globalement à la baisse, mais il faut dire que même l'espace géographique, mais le nombre de pays, par exemple, a augmenté. Over.
Finally, all our viruses are linked together. There is nobody giving us this virus. We are the one distributing it amongst ourselves. And that tells us that our borders also have challenges. The management of border-related activities, be it surveillance, routine immunization, social mobilization, advocacy, communication, we all have that demand creation problem because virus of Cameroon is linked to Chad, another virus of Chad is linked to Nigeria, Nigerian Zamfara is linked to this. We are the same set that is distributing the virus among ourselves. And that tells us that we are performing suboptimal within the region, especially along the borders and security compromised areas and other special populations.
Nous pouvons voir également que les virus que nous avions dans nos pays sont nos virus issus dans les 5 pays. Et les virus qui sont au Tchad, proviennent du Cameroun et ainsi de suite. Donc ça montre quand même la transmission au niveau transfrontalier. Et ça, on peut voir que nous avons une mise en œuvre de façon sous-optimale des ARS au niveau des frontières.
Now, if we look at also this is another way to look at it, and the more darker the color is, the more it tells you are going on the wrong direction. What we wanted to see is to see a white color, so to speak, in a summary. But if you take Nigeria, for instance, they moved from a very dark color on the week of the third quarter of 2023, which is very darker. As it reduces the color, then suddenly they have a spike and continue again in the last quarter of 2024 to reduce the burden. However, what we are seeing now, there is an upsurge when we compare quarter 4 and quarter 1 of this year. In the same vein, if you look at chart, you find that they have been a bit lighter in the quarter 1 of 2024. However, the colors continue to increase, which means there is an increasing number of cases that are picked. Where we have lighter colors are these. Now, this table is not fully completed. We have a virus in Central African Republic, which means that the last cell on the right side ought to be a lighter blue color instead of white. White is the desired color that we wanted to see, just to summarize.
Sur cette diapositive, nous pouvons voir une autre présentation des virus par rapport au trimestre. Et ce qui est attendu, c'est d'avoir des cellules qui sont beaucoup plus claires, vraiment blanches, pas colorées. Plus la couleur est foncée, plus on a un nombre de virus élevé. Et si on prend l'exemple du Nigeria, nous pouvons voir qu'au troisième trimestre 2023, nous avons 42 qui ont été confirmés. Et si nous allons au troisième trimestre 2024, nous sommes à 27. Et au premier trimestre 2025, nous sommes à 15. Peut-être la tendance est globalement vers une amélioration. Mais si on regarde également au niveau du Tchad, on va voir toujours cette tendance. Donc, ce qui est attendu, c'est d'avoir les cellules les plus claires possibles, les cellules blanches tout simplement. Et si on regarde en RCA, au niveau du premier trimestre 2025, il y a un virus qui a été isolé et ce tableau va être mis à jour. Over.
Also here is just to show that in both surveillance system where we have both the environmental as well as the AFP, we have been picking paces almost every week. That is what it just tells us. The green is cases from AFP, human cases, while the environmental are the ones in red. And what it means is that even for this quarter also, it has not been updated because we have viruses, as we know, from the environment, from Nigeria, as well as from Chad, and also in Cameroon.
cette diapositive, nous pouvons voir toute la répartition des virus. Et là, nous avons par mois et suivant les années. Et déjà, il faut préciser que cette diapositive n'est pas complètement à jour parce qu'on a eu des virus au niveau après le mois d'avril 2023. Et en vert, nous avons les virus détectés à partir de la surveillance chez les cas de PFA. Et en orange, rouge, les virus détectés à partir de la surveillance environnementale.
This is just a summary of performance indicators looking at the both core surveillance indicator in terms of stool adequacy as well as non-polio period of 3 per 100,000. What we can see is from 2023 to 2024, we look at how many of our districts will have achieved both the indicators at this level as well as 3 level. If you look at it, in 2025, we have 691, which means there is a decreased performance compared to 2024, where we have 834 that have achieved that performance. So it's some of our districts have dropped off. Similarly, if you look at the second color, lighter green, even at 3, we had 86 districts in 2024. Unfortunately, only 55 were able to make it. In that context, still, we can say we are not doing very well. So while our surveillance, you will see it across all the countries, there are pockets that are in yellow and there are fewer areas that are in red. In general, most of them have achieved at least one of the indicators of our districts in the whole of Lake Chad, with the exception of few areas in Niger and in northern Nigeria and some south part of Nigeria, where we have few areas that are in dots. Over. That have not achieved both indicators I'm talking about.
Excusez-moi. Excusez-moi, Leopold, can you hear me?
Yes.
Hi, Leopold, apologize. Our colleagues online are complaining that they cannot hear you very well. There are some messages in the chat box. They hear better Dr. Sadiq and were suggesting if you can use the same mic. Sorry for interrupting.
So just keep your mic.
Okay, we try. Maybe I can speak louder. Okay, thank you. I hope people can hear me now.
Are you hearing him?
Yes.
Yes, it's much better.
Lilian, is it okay?
Yes, Claude, are you able to hear Leopold?
Yes, it's okay now.
Yes, okay.
Is there anybody who can test online?
It's okay now. Okay, thank you.
Yeah.
Slide, okay. Oui. Et bien, sur cette diapositive, nous pouvons voir la performance de la surveillance des années 2023 à 2025. Et nous pouvons voir en vert foncé les districts qui ont atteint les 2 indicateurs. Il s'agit tous atteindre les 2 indicateurs principaux de surveillance de PFA. Et en vert foncé, nous avons les districts qui ont atteint avec un taux de PFA supérieur ou égal à 4. En vert clair, ceux qui ont atteint 2 indicateurs principaux de surveillance, mais avec un taux de PFA compris entre 3 et 4. Et nous pouvons voir, si nous allons en 2025, nous voyons que tous ceux qui ont atteint les 2 indicateurs avec un taux de PFA supérieur à 4, nous sommes à 691. Et si nous regardons en 2024, nous sommes déjà à 834. Donc il y a une baisse. Et si on compare encore à 2023, on est à 932. Donc on peut noter une baisse progressive avec le temps. Si on regarde ceux qui sont en vert clair, donc qui ont atteint un taux de PFA compris entre 3 et 4, là nous sommes à 55 districts pour 2025. Et en 2024, nous avons 86. Donc, vous remarquez que globalement, il y a une baisse de performance au cours de l'année avec le temps, la surveillance des principaux indicateurs de PFA.
Hello. So in general, I think Central African Republic, Chad, Niger, and Cameroon need to do a lot of work because majority of the 295 districts that have not picked any AFPKs, I'm talking about the white areas, they fall into that category. In general, Nigeria is on the higher pedestrian in terms of number of districts that are able to have picked some of these cases. But I think Chad, Central African Republic, Cameroon, and Niger has a lot of areas that needs to be addressed. And we will call on the countries to outline these districts and try to address it accordingly.
Il faut dire que j'espère qu'on me suit toujours bien.
Lilian, are you hearing him? The French?
Yes, I can hear him. I can hear him loud and clear.
Vous me suivez bien? Ok, merci.
Oui, on t'entend.
Ok, merci. Donc, des districts qui n'ont pas pu atteindre, qui n'ont pas notifié des cas de PFA, il faut dire que nous avions 295 en 2025 et ça concerne essentiellement, particulièrement le Cameroun, la RCA et le Tchad. Et on va peut-être discuter, au cours de discussions, on va comprendre des pays, ce qui se passe exactement. Et ce sont ces trois pays qui doivent faire des efforts particuliers en ce moment dans le cadre de la surveillance des PFA.
This is just a summary. We will not go into it, just to show the target population. What did we do in general context before the April round? There has been a joint launching by the five ministers of health or their representative in Jamena on the 17th. There was a joint call by the regional directors of UNICEF and WHO with the ministers of health of the 5 countries in full participation, and our colleagues from regional and global levels. They were there from both UNICEF and WHO. And then we have had synchronization along the borders of our countries. And in Niger, we had, although because of challenges of measles campaign that was happening, they had synchronization also along the border, not the whole district, but at least along health facilities that are sharing international border. So there is an improvement. However, in terms of validation of the level of preparation, which is a mandatory activity to be done before we start implementing, we have 168 of our districts that have no validation data. They did not verify the status of preparation before the April round. Nigeria conducted the directly observed administration of OPV, as well as they have conducted co-administration in 4 and 7 districts in Yobe and Jigawa states, where we had that case of type 3. Chad had used GTS to track the vaccinators. We'll show the details later in Jamena North. And then funds released from WHO is delayed or was delayed, no exception. The whole of Lake Chad Basin, WHO has not been able to provide funding at the time. And if I want to use Chad as a classical example, WHO funds came into Chad before the 15th of March. Chad is supposed to start vaccination on the 25th of April. They got the money on 22nd of April, 48 hours to the start of campaign. That was the time money left the coffers of WHO into the bank account of the Ministry of Health. And I salute the Ministry of Health of Chad because they were able to start transfer within hours of the money arriving in their account. However, you know it is not possible all districts, all areas to receive the money. This has repeated also with all our countries. In fact, in CAR, some districts did not get the money up to day 4 of the campaign. We have to shift their implementation to move into another date entirely. They could not start. Similarly, we have this issue in Niger to a lesser extent. And in general, UNICEF funds have arrived, but of course, they also have fewer pockets here. But we will say UNICEF have done it maybe up to 90% of the district receiving the money as appropriate, but I will not say the same for WHO. So we need to look at our internal issues to deal with that as the case may be. And finally, next, translate.
Okay. Le lancement de la campagne conjointe a été fait pour les 5 pays à Djamena. Les directeurs régionaux ont fait une rencontre en ligne avec les 5 ministres des pays membres qui constituent le LCB, le bassin du lac Tchad. Nous avons une synchronisation le long des frontières. Et il faut dire que pour le Niger particulièrement, la synchronisation a été faite avec les aires de santé qui sont frontalières. Le Nigeria n'utilise pas le dashboard de préparation afro. Et il faut dire qu'on a aussi noté que 168 districts de santé n'ont pas conduit la validation de la préparation. Le Nigeria a eu à mettre en œuvre les vaccinations polio en observation directe, ainsi que la co-administration du VPO bivalent et du NVP2 dans 7 districts de santé de Yobe et dans l'état de Jigawa. Il faut dire que le Tchad a aussi également mis en œuvre le tracking des équipes de vaccination. Les fonds ont été, les fonds d'UNICEF, les fonds OMS sont arrivés tardivement au niveau des pays. Les fonds UNICEF sont arrivés relativement à temps au niveau des pays et même au niveau opérationnel, et même dans des districts, et c'est peut-être quelques districts. Il faut dire pour l'exemple des fonds, notamment pour le Tchad, les fonds sont arrivés au niveau du pays un peu avant le 15 mars pour une campagne qui devait être mise en œuvre le 25 avril. Et là, les fonds n'ont pas pu être arrivés à temps au niveau du ministère, uniquement 2 jours avant la campagne. Et il faut saluer l'effort qu'a fait le ministère de la Santé au niveau du Tchad pour pouvoir anticiper. Et ce sont les étapes de transfert des fonds et pouvoir envoyer le plus rapidement possible les fonds au niveau opérationnel.
So just to make a summary, global level have sent these funds on time across all the countries. They have received the funds more than 5 weeks before the campaign. Where we have challenge is from the partners within the country to push the money into the Ministry of Health. Some in Cameroon, for instance, they have even pushed the money, but they still have gap between reaching it to the operational level. So the real hub or problem now is at the UNICEF WHO country office and then the Ministry of Health and so on, not the global level for the April round.
Pour ce qui est du transfert des fonds, il faut dire que les fonds sont partis du niveau global pour les pays et sont arrivés à temps et sont arrivés au moins 5 semaines avant le début de la campagne. Mais le challenge se trouve entre les partenaires au niveau des pays et le ministère de la Santé. C'est à ce niveau qu'on a eu des gros challenges pour pouvoir acheminer les fonds au niveau du ministère de la Santé.
One critical activity to know we are ready, because once funds are let, that means you finish micro-planning without money. You started advocacy, communication, social mobilization without real money. You go to training without money. You have already compromised the quality. By the time the money comes, it's just theoretical that we have received the money. It is difficult to pre-finance from pockets of government. Government also have a lot of activities, a lot of public health issues to deal with in their countries. So I want us to understand that once it is compromised, it might be leading to what we see now on the screen. On the left side is Cameroon, for those that don't know the maps. On the right side is Central African Republic. No validation in Central African Republic. Let's just say it that way. They did not validate the status of preparation to say, yes, all what we have been feeling on the dashboard, because our dashboard is, well, everything is green, 100%. Cameroon is green from the beginning of the variable to the last of the variable. Everything is absolutely green, all levels, 100%. Don't forget, there are districts in Cameroon that did not receive UNICEF funds up to the last day of the campaign. Yes, this is on record. But because we just feel it, we continue updating it, not considering the timeline on the tool, that if it says 2 weeks and you could not give it before 2 weeks, You gave it 7 days, you have failed. You have failed, that is all, because the activity has gone. So overall, look at the patches where there is no validation. We have 84 districts in Cameroon, while for Central African Republic, we just say that they did not do any validation. I think this is a fair summary to take it that way. And in Cameroon, where it has been done, the majority of them have the number of facilities they visited in that district are less than 50 in most of them, because it's either between 20 and 49, which is yellow, and that should not be the case. Validation is to tell us whether we are actually ready and we can go online.
Lorsque les fonds arrivent en retard dans le pays, on a du mal à mettre en œuvre des activités de qualité. Sur cette diapositive, nous pouvons voir à gauche la carte du Cameroun et à droite celle de la République centrafricaine. Et il s'agit des validations qui ont été faites pour les activités de la campagne. On peut déjà dire globalement qu'au niveau de la RCA, on n'a pas fait de la validation. Et au niveau du Cameroun également, nous pouvons voir que les validations ont été faites. Mais quand on regarde la proportion des structures qui ont été validées dans les districts, elle reste relativement faible. Là, nous pouvons voir par exemple, là c'est en rouge, nous sommes entre 1 et 19%, elle reste relativement faible.
Thank you. So we go to the next slide. It's the same approach in Chad. We have not done much. Only 66 of our districts were able to visit health facility catchment areas for validation, while in Niger Republic, only about, in Niger Republic, only about 12 of them health areas that were visited. It's still the same pattern. And with all respect to Nigeria, we don't have validation of Nigeria on the ODK server of Afro. I think Nigeria has a validation tool that does not reflect on the ODK server. So these are the two remaining countries that we have validation data. So a lot needs to be done if we want to move forward. With this type of map, I think we can ask ourselves, if we fail, why are we surprised? We have no basis to be surprised on that. Next.
Sur cette diapositive, nous pouvons voir la validation au niveau du Tchad et niveau du Niger. Le Tchad est à gauche et le Niger est à l'image de droite. Et on voit que les tendances sont généralement les mêmes. Si on regarde au Tchad, nous avons 66 districts de santé où on a validé au moins 50% des structures. Et au niveau de Niger, nous n'avons que 12 où au moins 50% des structures ont été validées. Donc, nous n'avons pas de validation pour le Nigeria, qui n'utilise pas un dashboard sur lequel nous pouvons capter cette information.
In terms of this slide, we are familiar with it. There is delayed. I think we have set it. Let's just go to the campaigns. If you cast all the campaigns across, you see the cumulative delays along the issues. And I would like us to also look at the red color on the top slide on the right side, where a lot of these delays can be attributable to the MOH, either sending requests in time or pushing the money towards the lower levels, districts, provincial and district levels, as the case may be. And these are the overall issues between 2024. This is cumulative, it has, and if you unfortunately, I could not see the 2025 one reflecting on the campaign's delay on the right side, but these are cumulative information and it differs from one country to another. I hope we will be able to improve in the subsequent rounds. Next.
Sur cette diapositive, nous pouvons voir les délais entre le moment où on met en œuvre la campagne et quand c'est le moment prévu. Et il faut dire que si nous regardons la figure en haut et à droite, nous pouvons remarquer qu'on peut voir le nombre de jours de délai et surtout la raison. Et là, nous pouvons voir que nous avons surtout les décisions prises par le ministère de la Santé qui ont pu impacter. Et nous espérons que pour les prochaines campagnes, des efforts vont être faits pour réduire, pour ne pas avoir de délai entre le moment planifié pour la mise en œuvre et le moment effectif qu'on fait la mise en œuvre.
terms of a cross-border, this is in the results, just to show that all our countries have been able to vaccinate children along the border. The only thing I'm saying is that some of our countries like Cameroon did not say how many Cameroonians I did not get the data. But overall, what I will say, the performance is great. More than 60% of the children that are vaccinated in the borders were accounted by Nigeria, and Nigeria was able also to disaggregate the data for all areas that they have borders. And we would like to congratulate them for that, because they vaccinated 143,000, which is more than 50% of the total children that were vaccinated along the border. And they did also Nigeria vaccinating Nigerians with 130,000 children. Cameroon, we need the objects. I hope in your presentation you will say how many Cameroonians you have been able to vaccinate.
Là, nous pouvons voir les enfants vaccinés au niveau transfrontalier, et on peut voir que dans tous les 5 pays du bassin du lac Tchad, tous les pays ont eu à vacciner les enfants au niveau des frontières, et le grand nombre d'enfants vaccinés a été réalisé par le Nigeria, autour de 143 000, et il y a quelques données manquantes. On pense qu'au niveau des présentations des pays, on pourra les avoir.
Additionally, we also thank Chad. They were able to go to the borders of Sudan, which they have also vaccinated about 4,000 children, apart from vaccinating children that are Cameroonians, Central African Republic, as well as Nigeria. There is minimal vaccination along the border of Chad and Nigeria because of the high level of security issues in that area.
Des remerciements pour le Tchad qui a pu vacciner à la frontière avec le Soudan, et également ils ont pu vacciner au niveau de la frontière avec le Nigeria, probablement lié à des raisons sécuritaires.
The results, this is LQS, just a summary. The countries will give details of that. What is important on this slide is to look at campaigns that were conducted in last year, 2024, 2 rounds, as well as in April this year. The table at the top shows that by all parameters, Chad has done worse than what they have done in the previous. This is the lowest number of lots that have ever passed LQS, which is 46% in April round, compared to the other rounds that we have had in 2024. The same way, if you look at by the proportion of failure, that the number of children that were found unvaccinated, in 14% of the lots that have failed in Chad, they have more than 20 children, while in additional 20 that have failed, an additional 20% of them fail with more than 10. So we have 34% of the lots failing with more than 10 children. And in the extreme end of Chad, there are districts that have failed with 53 children out of 60 children not FIMGAMAT. This is very, very the worst outcome of campaign in 2024 and to date in 2025 in Chad.
Nous avons les résultats du LQAS du Tchad pour 2024 et 2025, et nous pouvons voir dans le tableau que la campagne de avril 2025 a été la moins performante, et notamment au nombre par rapport à la proportion des districts qui ont été acceptés au LQAS. Et quand on regarde ces résultats également de façon détaillée, pour voir parmi les districts qui ont été rejetés au LQAS, le nombre d'enfants qui n'ont pas été vaccinés, la situation s'est encore détériorée. Et c'est ainsi qu'on a pu retrouver des districts de santé rejetés avec 53 enfants non vaccinés sur les 60 enquêtés.
Permit me to show this slide. I want us to look at this slide. This is how Chad did the failure, the mass. So when the summary there does not actually, it marks the differences, the magnitude of failure. Imagine in Salamat, we have a district that have failed with 53. If you go to one of the borders of Chad, which is Haji Lamis, you find where we have 9 circulating viruses this year. 9 circulating viruses. Haji Lamis. We have a district called Moito with 26 children that have failed. There is no province in Chad that all her district pass LQS, not even one. The capital of Chad, out of 10 arrondissement, number 1, number 4, and number 10 are the only ones that have passed LQS. So far, between 2024 to now, they have failed again this time. So 7 of the areas that we have conducted LQS in Chad have massively failed LQS. The failure that we consider moderate, yellow, is not even for discussion. These alone are 56 districts that have failed with 11 to 53 children in the lot that were not finger marked.
Là, nous avons une présentation de la performance du Tchad. Il faut dire qu'il y a le district, par exemple, de Mangeme dans la région de Salamat, dans la province de Salamat, qui a eu 53 enfants qui n'ont été non marqués sur les 60 enquêtés. Si on regarde une province frontalière comme celle de Adjel Amis, dans le district de santé de Moito, nous avons eu 26 enfants non marqués sur les 60 enquêtés. Et il faut dire qu'au Tchad, il n'y a pas eu une seule province dans laquelle tous les districts ont été acceptés au LQS. Également, nous allons regarder dans la ville de Djamena, où nous avons 10 districts de santé. Seulement le district du 1er, 4e et 10e arrondissement ont été acceptés au LQAS. Tous les 7 autres ont été rejetés.
It's not moving, my friend. Yes, out of 60. This is out of 60. Yes. Yes. 53 were not finger marked. 48 were not finger marked. 44 were not finger marked. And it goes on and on and on. Can you shift this slide for me? It's not moving, Chief. Can you go to the next slide? Let me give you try.
When I touch it, it will work. Normally, we point here.
I think the message is well clear. It remains there for all of us to think, to come up with practical solutions on how we can go forward. Next slide, please. Do it manually.
Even manually is not possible.
Even manually is hanging. It's not still moving. Yes, this is Cameroon. Cameroon has shown some minor increment between the rounds. So 62% of lots in March 2024 to 68, now to 71. They are still below the 80% cutoff, but they have shown by round they are improving in general. Next.
Au Cameroun, on peut observer qu'il y a une amélioration au fil des campagnes, avec 63% des districts acceptés au LQS en 2024 en mars. Et en octobre 2024, nous avons eu 68% et 72% en avril 2025.
Next. Next. Nigeria, for Nigeria, they have already achieved 91%. So we will say they have been consistent. But these are the districts that have failed LQS. The good thing is the failure is low. I would have preferred they put a yellow color there. I have said it before, because most of the districts fail with children less than between 4 and 9 or 4 and 10. But if you look at Sokoto South, which is the highest, Sokoto South is a metropolitan LJ inside Sokoto State. That is why we have. But in general, we will say, if you look at the border areas, most of our border areas are good. Where we have whites are security challenge areas due to some, and access is not moving very well there. But overall, we will say the failure in Nigeria is a manageable type of failure. There are few, only 9% that have failed. And at the same time, of the 9% have failed, most of them fail with less than 10 children within the lot of 60 that have failed, with the exception of Sokoto South and few others.
Au niveau du Nigeria, notamment la phase 1, nous pouvons voir que la proportion des districts qui ont été rejetés au LQS est de 9%. Et on peut aussi observer que parmi ceux qui ont été rejetés, le nombre d'enfants qui ont été non marqués est relativement faible, compris généralement entre 4 et 8. Et il faut dire que les districts qui sont en blanc, notamment au niveau de la frontière, la partie nord du pays, sont des districts qui n'ont pas pu mettre en œuvre les activités, n'ont pas pu mettre en œuvre le LQAS pour des raisons de sécurité.
Sorry.
Slide.
Next slide. Next slide. Next slide. So the white areas are areas we have no LQS data. Next slide.
Doesn't want to move again.
Nigeria phase 2 is coming. The data is going to come. They have just finished it. This is phase 1. Overall, the problems we have in the Lake Chad Basin, the major reasons why children are not vaccinated, cutting across the 5 countries, child absent, house not visited. Child absent, house not visited. And the reason is always children either in the farm or in school or outside. But this is not just for Cameroon, Chad, and CAR, but overall, child absent is an operational technical issue. It's the service delivery component that is failing the system than the receivers of the service.
Les raisons de non-vaccination globale à tout l'ensemble des pays du bassin du lac Tchad, c'est surtout l'absence et puis les ménages qui n'ont pas été visités. Et il faut dire que les raisons d'absence principales, c'était l'enfant qui était au champ, à l'école ou à voyager. Et il faut dire que ces raisons d'absence, l'absence est vraiment liée à l'offre de services pendant la campagne.
Next slide. This is the, okay. Just keep it here, no problem. The GTS that we have conducted in Jamena North district of Jamena province in Chad, we have tried to do it. We could not start from the initial period, the first 2 days, because of logistical issues that we have faced. But overall, what it has shown us in detail is that, one, there is a significant issues or gaps in the way we delineate borders or areas of assignment for the teams. There is a lot of areas of overlap between teams and living islands or pockets. When I say islands, some areas that have not been attended by any of the teams. So we have a lot of issues with the systematic covering of the settlements by the teams. 2, the development of daily implementation plans of the teams to define the boundaries between Team 1 and Team B. And then 3, the supervisory gaps, where supervisors if it is blown up, you'll find gaps between teams which they have left unattended to. And we have here issues that will improve the activity in the coming round.
Nous avons le tracking des équipes de vaccination qui a été mis en œuvre dans le district de Djamena Nord. Et il nous montre on peut tirer un certain nombre d'observations, notamment les zones couvertes par les équipes qui ne sont pas clairement délimitées et les zones. Et également, nous pouvons voir qu'il y a un problème de supervision de ces équipes de vaccination qui se pose. On pense que cette situation pourra être améliorée lors de la prochaine campagne. Over.
So many of the white areas means there is no data within that district. Teams have not been doing it. So we will take up these issues that are proposed, and it's going to be implemented as we go for the mayor round.
Les zones non couvertes, les points blancs montrent les zones non couvertes par les équipes de vaccination. Et il s'agit des situations qui vont être adressées lors de prochaines campagnes.
I think these are the immunity profile. What is important is that as we go outside our traditional target population, beyond the traditional under 5, we have for both type 1, the first row is for type 1, the lower row is for type 2. But overall, there are issues with immunity gaps in some of the areas that are highlighted in the red, in the northern parts of Niger, Chad, also in some parts of Cameroon, as well as southern Nigeria and so on. So, but this is just we need to take it with a pinch of salt as the variables that are used to develop these models.
Nous avons l'immunité pour le type 1 et type 2 sur cette diapositive dans le bassin du lac Tchad. Et nous pouvons voir, là nous avions en vert foncé, les zones où on passe immunitaire est plus élevée. Et on peut voir qu'il y a des gaps immunitaires. Si nous regardons un peu en bas, notamment au Cameroun et au sud du Nigeria, mais également au niveau du Tchad et du partie nord du Tchad et celle du Niger.
Next slide.
Mais ces informations doivent être plus avec pincette parce qu'il faut voir les variables utilisées.
Major issues. We have surveillance gap. We have discussed it. And these are the countries, especially this because of the orphan virus. And then we have issued with delayed sample shipment, which is Niger and Chad. We have discussed that before. France issues, we have raised it. Data is not disaggregated by type of population and location, especially when we are talking about special mobile population, border areas, and so on. There has been a problem with target population estimation for Chad, and it has reflected that a lot of areas, the vaccinators in some cases, we have seen where vaccinators have vaccinated more than 500 children per day. Then we have a lot of settlements that were not visited or have not been covered in Chad. And we have mentioned the reason why child is absent, and then the insecurity areas. I think in general, these are operational issues that needs to be addressed.
Nous avons quelques challenges qui ont été identifiés, notamment les gaps en matière de surveillance. Ça, c'est particulièrement au niveau du Tchad, Nigeria et au Niger. Et également, nous avons des délais de transfert des fonds. Ça a été discuté, ça c'est dans tous les pays du bassin du lac Tchad. Nous avons des données qui n'ont pas été désagrégées pour pouvoir permettre une analyse détaillée, également dans tous les pays du bassin du lac Tchad. Nous avons la cible qui a été sous-estimée, et ce qui a induit une charge de travail élevée et également des enfants qui ont été manqués. Ça, c'est au niveau du Tchad. Et nous avons des enfants qui n'ont pas été vaccinés dans plusieurs localités. Et ces localités n'ont pas été visitées. Ça, c'est au niveau du Tchad. Et nous avons aussi la raison principale de non-vaccination qui reste l'absence, suivie des ménages non visités ou non revisités. Et enfin, nous avons des enfants qui n'ont pas pu être atteints à cause de l'insécurité dans tous les pays du bassin du lac Tchad.
Next. We have profiled solutions. We can go into that in details, but I think overall, each of these issues have been addressed with country specifics. Regarding that, next slide, then next slide is the same thing. This is the preparation for the coming rounds. These are the dates of our campaign tentatively. Nigeria, we might brief us in their presentation, whether they will still be keeping these dates, but these are the dates that we have as it is now without any change.
Là, nous avions les dates de campagne qui avaient été retenues et nous allons voir avec les pays lors de leur présentation. Et
next. This is status of preparation for Mera. Cameroon, at the national level, they are at 91, and this is the issue. This is where I want us to understand very well. You see, when we have this type of chart, already they are 91%, 15 days away. The problem is because we are just going into the tool and updating it sometimes. I'm not by any means saying Cameroon is doing the wrong thing. I am just saying my opinion that it makes it difficult for me to wrap it. If, for instance, funds from the global level have not been received in Cameroon 5 weeks to the campaign, how can you reach 100%? Already the GPEI has failed. That is what it means. The funds reached Cameroon last week. How could it be 5 weeks away? The GPEI funds should reach country 5 weeks to the campaign. That is what it is said. So we should not be adjusting it because when we receive it at 2 weeks to the campaign, now we receive it, we just check the box and make it look. GPEI will think they have done a great, wonderful, excellent thing. And no, they have failed. The money did not come 5 weeks to the campaign. In the same vein, when you come from WHO or UNICEF to the Ministry of Health, once they miss that target point of 3 weeks, don't leave it as red. The same thing from ministry to the district to the province and so on. What we do is by the day 2, everything will look green because we don't respect the timelines. The timelines are set to say that the SOPs is saying that if we do not respect the timelines, we have diluted our preparation. That's what the SOP is saying. So already they have operational funds 100%. And if I ask Cameroon now, the money is not in the district. This is the reality about this dashboard. And I have called on the RRT, we need to find a way of blocking some of these debts. You cannot adjust it anymore. Once you miss the limit, the due date, you have to remain on that rate, but we can have commentary to say, however, the funds came 2 days to the campaign or 10 days to the campaign and not 5 weeks. And this is what happens. All the countries here have not received funds 5 weeks to the campaign from the GPEI. And I'm not saying it's just GPEI is at fault. Countries also have problems with budgeting. It takes them time to send the budget. When comments come, it takes them time to respond to the comments and so on and so forth. But the impact of this is that it does not allow us to do the preparation as guided by the SOP. So social mobilization, communication activities could not start. Or can start in theory, but maybe it's not there. The same thing about movement of vaccines and other logistics, immunization material. The same thing about micro-planning. It will be completed, the money is not on the ground. And then we see areas not visited, areas not developed, and we say we are surprised. There is nothing about surprise. This is simple logic. Don't say the last statement.
Nous avions le temps de préparatif de la campagne de mai 2025 pour le Cameroun. Nous pouvons voir que de façon globale, nous sommes à 74% et voir la performance au niveau national, provincial et des préparatifs des districts. Mais ce qui ressort, qui a été discuté dans les détails, c'est notamment comment ce dashboard est rempli. Ce n'est pas pour accuser le Cameroun ou les autres pays, tous se font de la même manière, mais déjà pour préciser que, par exemple, les fonds qui sont à 100%, là nous l'avons vu au niveau national, pourtant les fonds sont arrivés au Cameroun cette semaine, sinon la fin de la semaine dernière, et ce n'est pas 5 semaines avant la campagne. Il faut dire que ces fonds qui ne sont pas reçus à temps au niveau opérationnel vont entraîner la dilution de nos activités. On ne pourra pas mettre en œuvre des activités de qualité et à temps sur le terrain, et ce qui va impacter sur la qualité de notre campagne. Pourtant, si on voit le dashboard, il sera à 100% à tous les niveaux. Donc, c'est un problème qui a été soulevé et qui va être discuté avec la hiérarchie pour pouvoir permettre d'avancer.
Next slide. It's the same story. Next slide. This is Nigeria. This is their dashboard. I'm sure they will explain it further when they come, as 17 days to the campaign based on the dates that I have shown. If it is going to hold, this is what we have as of on our own dashboard in Afro. Next. Next.
Là, nous avons la situation du Nigeria qui est relativement la même. Et l'équipe Nigeria va peut-être apporter quelques explications quand ils vont présenter.
This is what we have from CAR. I know in their presentation they have different variables, but as of this morning, 5 a.m., this is what is reflecting on the dashboard for CAR.
Là, nous avons la situation de la RCA. C'est vrai qu'ils ont partagé une présentation avec des données un peu différentes, mais sur le système jusqu'à 5 heures du matin aujourd'hui, voici la situation de la RCA dans le dashboard.
Next. Chart, the same thing. This is what we have. They have 2% readiness level. This is what we have as of 5 a.m. this morning.
Là, c'est la situation du Tchad qui est à 2% de niveau préparatif global. Et cette situation reflète, a été captée ce matin à 5 heures.
Next. Niger, similar thing. This is what we have as 5 a.m. Next slide, please. The committee, I would like you to, if you did not listen to anything I have said, just look at the red lines and let us discuss tomorrow in details on that. I will not go. The positions in the organogram of the lecture coordination is not fully filled up to today. From the time it was created, we have positions in UNICEF too that has been advertised. We have somebody acting in that position covering logistics and social mobilization, but to say that they feel as they have planned, this organogram is not there. Secondly, operations and finance is not there. We have zero budget. From October to now, lecture coordination has not received $1 single to even buy coffee to drink tea in the office. That is the truth of the matter. Not to talk of whether we have car transport. We either take motorcycles or this is the truth. There is nothing to say it in any other language. That is what it is. I, as the coordinator, I don't have vehicle even when campaign is going. I sit in the office or I pay from my pocket and go and see an area that I have interest. Or I follow another consultant in his car. I'm not talking about BMGFO. This one's have money, consultants, McKinsey. I'm talking about WHO people that are there. I'm talking about that. And then secondly, so I want us to discuss, tomorrow we'll discuss all these things too. We have problems of IMS systems in some of our countries, in particular Chad and Niger. I think what we need to do is to advocate they have a full authority, a full power, a full delegation, and a direct line with the ministers of health to take decisions in the EOC, both in Chad and Niger. That is our own issue about it. So I think the incident manager of Chad, for him to perform, let him have full authority in the way on what to decide, how to decide with his own team in the EOC. So I think this is missing to some extent also. Niger has some ESC, yes, but also they have their own challenges. But the worst EOC setting is in Chad.
Cette diapositive fait appel à l'attention particulière des membres du comité. Et il faut dire que pour ce qui est d'un des points, notamment les postes au niveau du LCB, tous les postes ne sont pas encore pourvus. Nous avons par exemple 2 postes, un pour la communication, l'autre pour le vaccine management, qui ne sont pas toujours pourvus. Il y avait un collègue qui assurait encore jusqu'à là l'intérim. Et également, il faut dire que pour ce qui est des fonds, le LCB depuis octobre 2024 n'a pas reçu le moindre sou pour pouvoir fonctionner. Et également, il faut dire qu'on a des soucis fonctionnels, notamment avec les incidents managers, dont le celui du Tchad est le moins opérationnel. Il a probablement besoin d'être renforcé en termes d'autorité et aussi d'accès auprès du ministre de la Santé. Il existe également des challenges avec l'incident manager du Niger, mais ces challenges sont un peu différents.
So the committee, for me, as a person, I would like them to please tell us what were they expecting when we developed the plan in February, and we could not implement it? The plan is in theory, it's available, activities have been drawn, but it remains on paper from February to this time. So when we talk Gaskia tomorrow, we should be as open and to see how we can reposition the lecture coordination in a way that they will be responding to the issues at the border. We have seen our 10 areas of priorities. Mostly of them are all border-related things, or migrant population, or special mobile population. But unless we move out of that country in the chart, we have no, for instance, if we come to Nigeria, the Nigerian system helps us with vehicles to go to the border. I've been to the border, and other colleagues that came to Nigeria have been to the border. The same thing in Niger, the same thing and that. But within Chad itself, I cannot tell you what is happening in Abeshe. I can tell with the LQS, yes. So tomorrow, I will urge you, please, this is what we should be discussing about. The other technical, what to do with orphan virus, what to do with active cases. Our team is not weak, in my opinion. The team in the Lake Chad Basin is not technically weak. It is just they are handicapped. They have no capacity to take decision. They have no funding to take decision. These are the limitations they are facing. Not that what do we do with how to change absent child absent, how to support. These things, we know them. And I will learn more from you. I know it's open, but give us the resources, give us the position. Let us do the work. Thank you. I think this is the last slide. Oh, this is the tracking of funds for this round, and that is it. So it's open for discussion, but I will urge, I don't know Nigerian team whether they will prefer to take tea or they will present before tea. Yes. They have so many things to do, so they will present before tea. I think since okay. They will not participate.
People need a health break. Remember your own adults above 40, 50.
So it's a consensus. We have Nigeria online. Yes. Please, all questions. I will take 2 questions from the online team, but I will have preferred we give Nigeria to close the gap because they will give detailed discussions on that. But let me
Sadiq,
start with Girma.
we can wait. We can have our questions after Nigeria. No problem. If it's better for them.
Yes.
No problem at all.
Yes. Please, after Nigeria.
Yeah, of course.
Yes. It's already 11:30. I'm not fasting today. Dr. Abdul Qadir, we have the incident manager of Nigeria. He will lead us in the presentation for Nigeria.
Okay, good morning, all. Our colleagues online can hear me. Okay, so next slide. I don't know this French. I'll spend 5 minutes. The French will speak 2 minutes or 5 minutes. So at the end of the day, we end up spending 1 hour on Nigeria's presentation. Okay. Oh, I'm not covering anybody. Reading from this, my eyes and okay. So this is just a summary of where we are. Despite several efforts in 2024, we were not able to stop this transmission. We had 122 cases in 2024 and 166 in 2023. Our AP cases rose from 86 to 98. And this highlights that despite we have reduction, the AP cases are really high, indicating that we still have gaps As of week 17, we had about 21 cases, 17 from AAP and 5 from ES across 9 and 18 LGAs. Unfortunately, we had VB3 in Yobe. This also shows that we are still having issues around type 3. But I'm glad to announce I've already responded to this using BOPV and NOPV sometimes in March. And we're able to vaccinate over 6,000 children. We still have issues in country. One of the challenges are surveillance, campaign quality, community demand, and limitations in data quality. So these are some of the challenges that we have. And as a government, we've come up with some strategy shifts that we want to implement, which we applied in this campaign, and we're hoping that we'll use it in our May campaign. Okay.
Merci. L'équipe du Nigeria a présenté un résumé sommaire. Pardon? OK. Bon, en résumé, en dépit des efforts consentis en 2024, le pays continue à notifier les cas de poliovirus. Comme nous avons vu dans les slides précédentes, à ce jour, notamment en 2024, il y a eu en 2024, il y a eu 86 à 98 cas, et avec beaucoup de défis. Il y a également des défis au niveau de la surveillance, la qualité de la performance des campagnes depuis 2022 et la persistance des défis, notamment dans le cas de la sélection des équipes. Ils ont aussi à côté entrepris quelques innovations, notamment l'approche qu'ils appellent, qui consiste à l'identification, le dénombrement et la vaccination des enfants dans des zones à défi ou à sécurité compromise. Voilà.
Okay, so we go into the surveillance now. So despite our efforts at said, so this is just showing us where we are in 2023, 2024, and 2025. So currently in 2025, we had a total of 22 detections. If you compare that to 2024, where we had just 122. So on the side, on the left here, just showing a geographical representation for AP cases, and then the below chart is showing us ESs. Voilà.
Alors, quand nous regardons le nombre de cas détectés par année, en résumé, nous constatons une baisse de 2023 à 2025, allant de 166 cas en 2023 contre 22 en 2025. Et les slides, enfin la partie en haut, nous avons les cas de PFA, en bas, les cas détectés à travers la surveillance environnementale.
Okay, so this slide is showing us the VP3 that was detected in Yobe and what we did. I think in the slide Dr. Sadiq presented was not 7 districts. There were 8 districts, 5 in Yobe and 3 in Jigawa. So the map here is showing us, the red is where the had the index case, and in the middle here we are showing you the details of the case, and then also these are another details for the case. Well, just say that we used BOPV and OPV2 in the ward where this child was found, and they were able to vaccinate 6,922 children in that area. And then just to report that the acceptance of the BOPV and NOPV, the co-administration, was very high. We had no issues with refusal.
Merci. Alors, juste, cette slide parle de, vous savez, en 2025, le Nigeria a détecté aussi un cas de type 3. D'abord, pour préciser, la slide que Dr Sadiq a présentée, il a parlé de 7 districts ou LGA qui ont fait la riposte, mais en réalité, c'est 8, comme présenté ici. Et dans ces 8 LGA-là, ils ont fait ces 8 LGA qui étaient de 2 États, notamment l'État de Yobe et Jigawa. Ils ont fait la co-administration de bivalent et de NOPV2. À l'issue, ils ont vacciné au total 6 924 enfants. Et un point fort à préciser, c'est qu'il n'y a pas eu de cas de refus. La population a bien accepté cette co-administration. Donc, ils ont eu une très bonne expérience.
Okay. So the next slide here is trying to show us, the appearances of the viruses quarterly. The trend has been that in quarter 3, that is where we usually have the highest transmission. And you can see in quarter 3 of 2023, we have about 41, and in quarter 3 of 2024, we had 42. So what we are trying to show here is our peak, the highest transmission period for the virus is in quarter 3.
Merci. Alors, cette slide, nous essayons de montrer un peu à quel moment de l'année nous avons le pic souvent de nos cas. Et comme vous le voyez, que ce soit en 2023 ou en 2024, c'est notamment au 3e trimestre de l'année que nous avons le pic de nos cas. Nous détectons le plus de cas. En 2023, par exemple, nous avons détecté 41 cas au 3e trimestre. Et la même chose en 2024, 42 cas au 3e trimestre.
And then the map is showing us the pending PV2s that we still have in the lab.
Et la carte nous montre les cas encore que nous avons en attente des résultats au labo.
Okay. So this slide is showing us the lineages that we have in country. Currently, we have about 5 of them. But we are trying to stress here that ZAS1 has really traveled out of the shores of Nigeria to other African countries, and it still continued, to spread. However, we also had Borno 1, Yobe, and Katsina. We are glad to say that we were able to contain this. This is no go, it didn't spread. However, Katsina moved to 2 other states. We are glad to say that the new lineages that were discovered, were able to contain them. Since we discovered it in 2023 and 2024, we've not seen them anywhere again. But our worry is ZAS1 that has continued the spread.
Alors, cette slide nous parle des cas et les liens que nous avons, que ce soit dans le pays et hors du pays aussi. Alors, la bonne nouvelle, nous parvenons vraiment à contrôler certains cas. Et sauf que la crainte, le nouveau cas qui est détecté, c'est vrai, pour l'instant, nous parvenons à contrôler ces cas, mais nous craignons que ça soit transmis, ça soit exporté vers les pays voisins du bassin du lac Tchad.
Okay. So now if you see the time series on the right. You can see ZAS1 from Q1 of 2023. It continues to increase. And then peak was in quarter 3, and then it goes down in 2024. Its peak was also in quarter 23. So you can see it continues to spread unabated.
Alors le défi, comme il a dit, c'est vraiment le type des amphara qui continue encore à s'étendre à travers les différents trimestres, comme nous voyons sur la slide.
Okay. So this slide is showing us how we've performed, the core indicators. You can see that we've improved from 755 to 733. So what we are showing here is the green areas are the districts that have achieved the 2 core indicators, while the yellow areas are those that have achieved 1 indicator or so. So overall in 2023 and 2025, we achieved 755, whereas in 2024-2025, we have 750. So this indicates that we've done better in 2024 as opposed to 2025, and we still have some surveillance gaps, which we are really working on to ensure that we really improve. So what we're trying to show here is, at the subnational level, the core indicators are looking very good, but we have issues at the subnational level, and now we have surveillance gaps at that level.
Alors, cette slide parle de la performance de surveillance au Nigeria. Comme nous le voyons, de manière globale, les 2 indicateurs phares se portent bien, et presque au niveau, à vue d'œil au niveau global, tout va bien, tout se passe bien. Les États arrivent à atteindre les 2 indicateurs bien, mais toutefois, quand nous désagrégeons ces détails-là et que nous partons jusqu'au niveau opérationnel, au niveau district, au niveau aire de santé, par exemple, ou district, nous avons des challenges, nous avons des difficultés là-bas. Là-bas, il y a des districts qui n'arrivent pas, ou des LG qui n'arrivent pas à atteindre ces 2 districts, ces 2 indicateurs.
Okay, so this slide is showing us the orphan viruses that are detected from 2023 to 2025. The first year is showing us in 2023 we had 13, and in 2024 we had 25, and currently in Q1 we have 14. So you can see, if you compare 2023 and 2024, there's a rise in the number of orphan viruses by almost double to 25. So this is not unconnected with, in April 2024, we started implementing surveillance improvement plans strongly and very, judiciously. And from there, we started seeing increase. So before then, our surveillance was not really too good. But by the time we start implementing the surveillance improvement plans, we now start seeing, so our sensitivity for surveillance increase, and that is why we are started seeing this rise. So we're able to, detect these orphan viruses because our sensitivity for surveillance has now improved from April of 2024, sorry.
OK. Ici, nous faisons le résumé par un des cas orphelins, des virus orphelins détectés au Nigeria de 2023 à 2025, au premier trimestre 2025. 2023, nous avons détecté 13 cas, comme vous le voyez. 2024, 25, contre 14 cas d'abord détectés au premier trimestre. Alors, il est à souligner que entre 2023 et 2025, il y a eu un pic, il y a eu vraiment une augmentation des cas détectés. Et cela pourrait être expliqué par le fait que nous avons augmenté la sensibilité de notre système de surveillance. Donc, du coup, comme vous le savez, quand la sensibilité du système de surveillance est bonne, vous parvenez à détecter plus de cas. Alors, c'est vraiment l'une des raisons pourquoi nous avons détecté ce nombre élevé de cas en 2024 et maintenant en 2025.
Okay, so this slide is showing us weak routine immunization, and then where we are having transmission of the virus. The red areas are areas where we have low routine immunization, and you can see we juxtapose them with where we are having viruses. So in summary, this slide is showing us the same areas where we have low routine immunization are the same areas where we are having the highest burden of the virus.
Merci. Ici, c'est vraiment, nous essayons de montrer la performance de la vaccination de routine contre la détection des cas et à vue d'œil, nous constatons que les États où nous avons vraiment la faible performance de la vaccination de routine, notamment en Penta 3, sont ces mêmes États où nous avons le plus de cas détectés.
This therefore stresses the importance that SIA alone is not enough to stop transmission. We need to strengthen routine immunization in all its ramifications.
Ce qui demande à suffisance que les AVS seulement ne peuvent pas arrêter la circulation du poliovirus. Il nous faut renforcer ces cas de AVS par une bonne vaccination de routine.
Okay, so this is showing us, the evolution of the virus. In the last 6 months, we have 31 of them in 24 districts, and in the last 9 months, 74 in 54 districts, and then in the last 12 months, 103 in 61 districts.
Ici, nous avons la tendance de la détection des virus. Alors, aux derniers 6 mois, nous avons détecté 24 cas. Oui, nous avons détecté 24 cas, 31 cas dans 24 districts. Et dans les derniers 9 mois, nous avons détecté 74 cas dans 54 districts contre 103 cas détectés dans les 12 derniers mois dans 61 districts sanitaires.
Okay, I think we've talked about this before, just showing us our core indicators. So I'll just move. So we want to show this slide to tell you that it is a cross-border meeting, to show you that at our borders, our core indicators have been met, and we don't have much problems in the borders, except in Borno, where we have in MOBA, where it's just one of the indicators that were achieved. Otherwise, and then somewhere around for 2025, we don't have any issues with the borders, except in MOBA, LGA in Borno, where we have only one of the core indicators that were achieved.
Alors ça, c'est la performance de la surveillance le long des frontières au Nigeria. Comme nous le voyons, il n'y a vraiment pas assez de problèmes. De manière globale, tous les districts le long des frontières arrivent à atteindre les 2 indicateurs, sauf au niveau de l'État de Borno, où il y a quelques LGA qui n'ont atteint que l'un des 2 indicateurs de la surveillance.
Though of course we still had some viruses, like in area of Sokoto and Borno areas that are close to the border.
Toutefois, nous avons quelques virus qui sont détectés le long des frontières, notamment à Sokoto et à Borno.
So the next slide just showing us our surveillance activity in inaccessible areas. So I wouldn't want to dwell much on this. So this just showing us our accessibility map. We still have issues of insecurity in Nigeria, and we are not able to reach a lot of places. And all these areas that you see in red are areas that are still very inaccessible. Like you can see areas in Borno, Zamfara, and Katsina. Parts of Nasarawa are still having inaccessibility problems.
Alors ça, c'est vraiment, ça nous montre des zones encore inaccessibles au Nigeria. Les États comme Zamfara, Kaduna et Borno nous avons Katsina. Et nous avons dans ces États-là quelques LGA qui restent inaccessibles.
So now we are now going to SIA performance and what we did for the campaigns. So this was the scope of our campaign. Above is in 2023, and then below is in 2024. So in 2023, we had one national round in September, and then like another one sometime in November. But in 2024, there was no any national round, they were all sub-national rounds.
Alors ça, c'est la performance des AVS que nous avons eu au Nigeria de 2023 à 2024. En 2023, nous avons eu une campagne nationale qui s'est réalisée dans tous les États, et ça, c'était au mois de septembre. Pour 2024, nous n'avons pas eu une campagne nationale. C'était vraiment avec des campagnes en bloc.
Okay, so you're showing us results of districts that were not able to resolve non-compliances in 2024 and 2025. So if you look, for example, if you compare R1 of 2025 and R1 of 2022, you can see issues around the northern, southern part of the country where we have no issues. We are now seeing issues of non-compliances also in the northern part, in the southern part of the country as compared to others.
Alors, et ça, c'est la carte des refus, et des refus qui restent encore non résolus après les campagnes. Et si vous regardez bien, vous verrez qu'on a moins de cas de refus non résolus dans la partie sud que dans la partie nord.
So what we saw in this round, April round, was that in the southern part of the countries where we used to have non-compliances, it is now on the increase, and that is why you are seeing red in the southern parts of the country.
Alors nous essayons aussi de montrer au sud du pays, parce qu'auparavant, nous n'avions pas de cas de refus au sud du pays, mais actuellement, nous avons commencé à avoir des cas de refus lors des campagnes. C'est pourquoi nous avons souligné ces parties-là en rouge.
Okay, so the next slide is showing the reasons why children were not vaccinated. And the highest is, I think Dr. Sadiq has mentioned, is child absence, and this cross across all Lake Chad Basin. And the other one, the second most common is house was not visited, and then non-compliance. But I think the greatest is child was absent, not absent.
Alors ça, c'est les raisons de non-vaccination au pays. Dr. Sadiq l'a dit, les deux raisons phares de non-vaccination dans les 5 pays du bassin du lac Tchad restent les enfants sont absents ou le ménage non visité. Alors, en plus de ces deux au Nigeria, nous avons aussi des cas de refus qui s'ajoutent à ces deux sur les raisons de non-vaccination.
So we did a national campaign, but we are still awaiting the results of Block B, the southern parts. Okay, so you're showing us settlements that were visited, not visited by vaccination teams in 2024. So if you look, areas where you have the red, areas where more than 50 settlements were not really visited. It was worse in R2 in 2024, where there was slight improvements in R3 of 2024, that was November. And it was March, where it was better in November of 2024.
Alors ça, c'est une slide qui nous montre des aires de santé, ou LGA comme ils les appellent ici, les aires de santé non visitées par les équipes de vaccination en 2024. nous avons vraiment rencontré plus de problèmes autour de 2024. Et à partir de là, à partir de 2003, 2004, nous avons eu une petite amélioration, une diminution significative dans le nombre d'aires de santé non visitées par les équipes de vaccination.
Okay, this is for this round. Sorry, we are not able to put it on a map. This is showing the settlements that were not visited by teams in the just concluded rounds. This is by states, and then the number of settlements that were not visited, and then the estimated children that were not really visited by the vaccination teams.
Alors, on est vraiment désolé, on n'a pas pu mettre ça sur une carte, mais ça montre aussi le nombre d'aires de santé non visitées par les équipes de vaccination. Vous avez la seconde colonne qui nous parle du nombre d'aires de santé et la dernière colonne vers la droite qui nous parle du nombre d'enfants que nous estimons qui ont été manqués dans ces aires de santé qui s'élèvent à 4 864 806 enfants, une estimation de moins de 5 ans.
Okay, so I think this is generic. I'll just jump this. These are generics. Okay, so this is the report of the campaign we did in just completed April campaign. So April campaign, we're able to reach 71% of the settlements were reached with geo evidence. So by this it means we have geo evidence showing that these communities were really reached. And each slide is showing us, for example, in Kano, we're able to reach 95%. And then in Benue, 43% of the settlements were reached. And then in the southern parts, in Lagos, 99 were reached. And then in Ebonyi, 51%. But overall, 71% of all the settlements were reached with geo evidence.
Alors ça, c'est vraiment une slide qui nous parle des zones que nous avons pu toucher lors de la campagne passée, et avec évidence à l'appui, avec l'évidence des coordonnées GPS à l'appui. Au total, nous sommes sûrs que nous avons touché 71% des zones, et avec 29% qui n'ont touché. En haut de cette slide, c'est la partie nord. Par exemple, dans l'état de Kano, nous avons pu atteindre 95% de cet état, et contre 43% à Benue State, à l'état de Benue. En bas, c'est la partie sud. Dans la partie sud, nous avons touché 99% à Lagos, et contre 51% de la zone touchée au niveau de l'état d'Ebonyi.
Okay, so we just want to stress here that in the last campaign in November of 2024, 80% of the settlements were reached. Okay. But in this campaign, 71, so that's a slight drop. And the reason for the drop was that the e-tally we are using, people are not reporting on it. And then our colleagues in the southern part are using the e-tally for the first time. And this is what accounted for the reduction from 80 to 71%.
Okay. Alors, il est à souligner que lors de la dernière campagne de 2024, nous avions atteint 80% des zones, et contre 71%, c'est tout. La raison est que les fiches de pointage digitalisées que nous utilisons, tout le monde ne rapporte pas, le rapportage n'est pas exhaustif, Ensuite, les collègues de la partie sud, c'est la première fois qu'ils utilisent ces fiches de pointage digitalisées.
Okay, so this is showing us the vaccination coverage. So overall, 81% of the children were vaccinated for the April campaign. For example, in Plateau, we have 91% vaccination coverage. And in Kano, we have 68. And if you go to the northern part, we have 99 in Oshu. And then in Edo, we have 67.
OK. Alors, ça, c'est la couverture administrative de la campagne passée. Au total, nous avons une couverture de 81%. Et ce qui se présente ici par État. Au nord, nous avons l'État des Plateaux, qui a la plus grande couverture, à 94%, contre 68% dans l'État de Kano. Au sud aussi, nous avons l'État de Osu, qui a atteint 99% de couverture vaccinale, contre 65% dans l'État de Abia.
So we also want to compare this with November last year. In November last year, the vaccination coverage was 87%. That shows there's a 6% decrease, and this is still unconnected, with the Italy report that we mentioned earlier. People are not really reporting on the Italy as expected.
Et nous voulons aussi comparer les couvertures des campagnes passées contre la campagne de mois d'avril. Pour la campagne passée, nous avons atteint, on était à 87% contre 81% de campagne mois d'avril. Et cela est encore lié du fait que à l'utilisation de la fiche de pointage électronique.
Colleagues, sorry to interrupt. We have interpreter in the cubicle, and you can just switch into the language you want, French or English. Online. Those that are online, please feel free to switch to the language of your choice, French or English. English is one, correct? What? Okay. So there is French and English. Please just go ahead. We'll ask the incident manager of Nigeria to just continue presenting without any further interruption.
Okay. Okay, thank you. So this slide is showing us what happened during the April campaign. And we are trying to show the launch that happened in Jamaica. And you can see here the Honorable Korean Minister of Health for Nigeria and his counterparts from the Chad Basin were at that launch. And you can also see the Honorable Korean Minister of Nigeria vaccinating children. We also want to announce that 49% of the settlements in the borders were able to reach them with geo-evidence. We are not able to go higher than this. This is because of the insecurity that we have in these border areas. So the map here is showing us where we had the vaccination. And in all, 49% of the settlements in the border regions were really rich with geo-evidence and were able to vaccinate over 19,000 children. So the bar just below here is showing us in each of the states where the number of children that are vaccinated. So for all the states, 8 states in the border areas, over 143 children were really vaccinated. In the border area of Jigawa, over 6,000 were vaccinated. And in the border area of Katsina, about 31,000 were vaccinated. So we still have issues in areas where we are insecurity, we are unable to reach them. We want to reach them with during when we are doing our RIC. So and in between our activities, we should be able to reach them then. So the next slide here is just showing us our activities that were conducted from 2023 to present. And then if you look, and then the LQAC resources, how we performed. So if you look like in May of 2023, where we had NOPV2 and FIPV, we had NOPV of pass mark of 69 and FIPV 64. Then when you come to December 2023, the LQAS was 100% in all the LGS that were surveyed. And then when you come to September 2024, it was 95.1% in all LGS surveyed. And then in November 2024, it was 89%. And our last campaign that we had in April, it was 91%. So there was market improvement, really. The trend is that we'll be improving over time in our LKS reports. So this is just showing how we fared from 2023 to from January 2024, it was 73. This we improved in August to 97, and then now we are also at 91. So this is show that we've been doing very well with our LQS, but unfortunately,
We can no longer hear you in the room. It's muted.
Same from my side.
Yeah, there's the room is mute. The meeting room, it says that it's muted, Dr. Usman.
Oh.
So it's there now. Could you confirm now, like you are able to hear us on the virtual space? Over.
Yes, we can hear the room. Can you test the mic?
Okay, okay, okay. Thank you. So, is it okay now for the presentation to proceed? I can see someone, Kasil said, okay. All right.
Can you hear me now?
Yes.
Okay. So thank you. So this slides is showing the Arab performance for Nigeria based on NDHS 2023. It shows that our performance is still not optimal. The target was 73, and then the national average was 53. And it goes to show that most of our states are not doing really well, and the states that still have the low rate of immunization are the same states where we're having the viruses. And this included Sokoto, Kebbi, Zamfara, that had less than 15% coverage. So where we had the highest coverage were really in the southern part of the country, states like Cross Rivers that did very well, and you can see currently we don't have any virus in Cross Rivers. So the importance of this slide is that RI is really very important. Doing SIAs without strengthening routine immunization will not really solve this problem of the viruses. Next slide. So this is just showing us where we have our zero doses. I think I don't want to dwell on that. And this is just comparing routine immunization that were planned in 2024, the outreaches, and then that in 2025. So you can see there's not really much difference, but a lot of work is really happening in the outreaches. If you compare the dark green, you can see in 2025 it has even reduced. And this is because the funding for outreaches has, is not as much as we had in 2024. So just comparing BOPV and IPV coverage by districts between 2024 and 2025. So you can see it's just really marginal improvement. And if we compare this to the NDHS 2023 that I just presented, it's showing the same picture. This is just saying the performance by a province. I think this we've showed, but this is now going granular in each of the states, and each of the districts is being mentioned here. So 42 out of the 744 districts have less than 50% IPV coverage, while 31 out of the 774 had less than 50% of BOPV coverage. So this still points to the fact that routine immunization is really very low, and we really need to optimize it and strengthen routine immunization so as to boost immunity of the population. So this is just showing us the same thing, the provinces where routine immunization and OPV are still having a current issue. So just a breakdown in each of the states, how they are faring in BOPV in 2024 and 2025. So you can see in 2024, they even did a lot better compared to in 2025. Though it's too early to talk about 2025 because we are just in Q1 now. So this is just showing us graphically the BOPV and IPV optics in 2024 and 2025. If you look in 2024, BOPV and IPV optics were really not good. But in 2025, it's a lot better. But of course, this is just for Q1. It's not for the entire. So we cannot really conclude here that we are really doing very well with BOPV and IPV in 2025 because it is just the data for first quarter. Okay. So these are some of the challenges, and there are a lot of things that we did to, we had issues around campaign quality, this we've mentioned. We have issues about team selection, where a lot of political interference comes in. And we know if you don't have good teams, you don't expect to have good results. So it's garbage in, garbage out. So this is a serious problem for the program, and that is why we have to come up with the strategic shift, to ensure that teams are well selected and ensure that the right people who are selected, trained, are the same people that appear in the teams. So this we're able to do in this round. It has really helped us. We also have issues around community demands. We are still having a lot of issues. People are still not trusting the program because they are seeing their problem is hunger. You're not providing them with food, and you still come to us, forcing us to take your vaccines. We have issues around insecurity. You're not taking up insecurity. We're asking us to, come and take vaccines. So all this were, involving our traditional rulers who are helping us to ensure that this release goes down. Also have issues about accountability. Any program that you don't have accountability is as good as it's as good as nothing really happening in that space. So for us as a country, we want to hold our accounts accountable, both individuals and partners, and this we've already started. In the last campaign, we had issues where some teams had issues and we had to sanction them. Some individuals did something wrong and they were sanctioned. Partners did something wrong and they were cautioned. So this is the way to go, and it's a continuous exercise for us. We also have challenges of surveillance. We also have issues around our data, but all these we are working to ensure that we really improve. So these are some of the things in my earlier first slide, we talked that we had, because of these issues, we proposed some strategic shifts in the country. And one of them is we introduce, team selection. And for the team selection, what we said here is we want everybody to nominate teams, but after nomination, they must pass through a process. Because of this interference, political leaders are bringing their candidates. And what they want is once they nominate a candidate, whether he passes or not, he must participate in the campaign. But for us, we said that should not happen, and that's why we brought the issue of team selection. You can bring your candidate, but he must pass through all the processes. If he passes, he gets to the last. If he doesn't, he drops. So this we've started using this campaign, and we've also involved our traditional leaders to ensure that we get these team members within the locality. In the past, what we see is that teams are brought from other areas to work in an area that is not their terrain. They are not familiar with the terrain, and the people in those areas do not know them. So we have higher issues of rejection. But with this current, what we are doing involving tradition to ensure that they vet the people who are working, that they are really from that community, really helped us. Also brought issues around independent observers. These are people who are not part of the program, but ensure that they look, observe the process independently and report to us independently what really transpired during the selection process. We also introduced directly outside vaccination in Katsina and Sokoto states. Fair finger marking was a problem for us, and this happens inside the households. So the teams usually connive with the caregivers, because some of the teams are outside, they are not able to see what happens, and that's why we introduced this directly observed. So the children are being brought outside of the rooms to like a veranda where all the team members will be there and watch the child being vaccinated. This we did in Sokoto and Katsina, and it reduced really the occurrences of fake finger marking. And it's one of our strategic shifts that we really applied. Also used independent team supervisors and closer supervisors so that we're able to monitor our teams. In some cases, we introduced like in one-to-one, And some areas we did cluster supervisor, where one supervisor will supervise 3 teams. And this is just to enable us to really monitor the teams, you know, bumper to bumper. Because once they know that there's somebody monitoring them, they tend to do the right things. So we also have issues around surveillance. We are trying to institutionalize health tool sampling, especially in insecure areas. And then for community demand, as we see, we introduce what we call the CSO-led strategy, where we have civil society organizations who are based in those areas to help us, you know, drive demand generation. And for this campaign, they were able to resolve a lot of non-compliances for us. And then for IEV, we've enumerated a lot of children. Unfortunately, we are not able to use the data because of some challenges. But this, we are hoping to use the IE for May campaign. So, these are our challenges for the program that I just mentioned earlier, but these are the challenges that are specific to cross-border. One of the greatest challenges here is we still have issues around the joke. I think this is too political. What is happening in the in the lecture area, geopolitical situation in the ECOWAS region. This is still ongoing. Then we have issues around synchronization. Shifts in the dates is still a problem. We prepared in April, then suddenly Niger shifted their dates. Well, that's not withstanding. We are still able to synchronize. We have issues around surveillance. Insecurity is a problem. And if I see in this slide we just presented, we are unable to reach the number of children we reached. Issue of lack of SOPs to guide cross-border activities, and I think Dr. Sadiq has mentioned something about that. They are having challenges, so that may not be unconnected with that. Communication, you can see here I'm the only one speaking English. Every other person here is French, so we still have issues. So we should find a way how we can, you know, bridge this gap. We also have non-compliances and inadequate funding. I think the LCC tax is also facing serious challenges based on, you know. So what we are trying to do for us, what we are recommending is that there's a need for us to really map up stakeholders around the border. This, a lot of us have been done, and also the plan of action should be developed jointly so that we all seem to be working together. Systematic regular coordination meeting is very critical. As this is happening, currently our colleagues are having, you know, cross-border meeting now currently with the Lake Chad Basin. Dr. Bamusa just called me, sent me a message they are currently having. So this gladly is happening. We also need to really deploy joint SOPs for our international border activities. So we're all doing the same thing. So whatever Nigeria is doing at the cross-border should be what Niger should be doing. We should be doing things differently. We should also have a way of systematically tracking our inaccessible settlements so that every settlement is reached with due coordinates. So this is our plan. I think I would like people to really pay attention to this. For us, April has come and gone. Alhamdulillah, I think we've not done badly for our April campaigns. We're able to reach 71% of the settlements with due evidence, and 81% of the children were vaccinated. So our plan, next plan now is for May. I want to announce here that for Nigeria, we are going to shift for the following reasons. One, we don't have funding from ORPG for this yet. So there's no funding for Nigeria. We've not even gotten approval for the May funds. That is number one. Secondly, as a country, we've done our April campaign. We've learned lessons. And we're trying to see how we improve on those lessons so that we can better our April campaign. So we have challenges in the April campaign. So we want to sit down as a country, reflect on what went wrong and what we did well, so that we can do better in May campaign, sorry. So our proposed date for me is now 14th to 17th of April. The scope, we are still discussing the scope, and once that is finalized, we will share with the lecture basin tax team. But for September and October, this still stands, and we intend to integrate in October round with Mrs. and Rubella. Is it June? Okay, June, sorry. June. Sorry, June, yes. So we just want to showcase what we did in Yobe and Jigawa, where we had a co-administration. And you can see we were able to vaccinate close to about 500,000 children separately for the BOPV and NOPV. And in the areas where we did connected LPSs, where we had the co-administration, all the
Hi, colleagues. I think we lost the room again.
We can't hear you, Dr. Sadiq.
Hello? Are you hearing online?
Are you hearing online?
Yara?
Are you hearing online? Are you hearing online?
Can somebody respond? Somebody respond.
The sound is very bad. There's an echo. There's an echo. There's an echo.
Yara, you are not audible.
You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible. You are not audible.
Somebody has how many microphones? Can we reduce it here in the hall? All people that are physically here, please, reduce the volume. So online. Okay, Lara, can you respond? Do you have issues with all presentations so that we take it up?
We can hear the room, but there's a lot of echoing. Okay.
Lara,
Okay.
there is some technical issue. We are not hearing you. Okay, let's start. The people online wants to hear the questions also on this side. Would like to hear some questions. Just a minute, please. Let's be we are sorting the technology here.
Okay, no, we can hear.
People in the hall, you
It's
can
clear.
go and have tea also. Take additional. For Mike Mwanza, give him coffee.
Can you hear me, Dr. Sadiq? No. Can anyone online hear me?
We can hear you. I don't think they can hear us.
Okay.
I think they've muted, not them. I don't know, something is muted. I guess it's a coffee break?
I guess.
Yeah, people seem to be getting up.
All right.
Okay, we can
Just
assume it's
a
a coffee
minute,
break.
online colleagues, we are not hearing you. They are
Can you
trying
hear
to
us,
find
Dr.
out
Sadiq?
why.
Okay, okay.
Now you are clear.
Oh, good.
Great.
We can hear you also.
Yeah. Thank
All
you.
resolved.
Resolve.
Yes.
Resolve. Okay, so if you have questions, Lara, then is she around CDA? Girma? Okay, Lara, go ahead.
Hi, sorry, what was your question, Dr. Sadiq?
If you have any of the comments, questions
Oh,
on
yeah,
all
thank
the
you.
presentations.
I'll go quickly because I'm sure people want to take a break. But thanks, first of all, for all the great presentations. I think the main one is maybe for our discussion tomorrow, but the main takeaway from the excellent and very honest and frank presentation you did, Dr. Sadiq, was very helpful, is I don't see how we are in a capacity to conduct quality campaigns end of the month. So we seriously need to rethink how we move forward. Points well taken on the cross-border LCB support and what you need to be operational, and the different points as well that were raised for Nigeria. I think what would be helpful out of the LCB review today is to identify priority actions that we will be tracking and aiming to resolve per country and at sub-regional level before the next round to make sure that it is a successful one. The situation in Chad notably is quite scary. Thanks.
Thank you very much. All colleagues from other online, it's open. Yes, Andrea?
Thank you so much, Kodo. Thank you for thank you for the great presentations. Just to highlight that for Cameroon, we vaccinated 11,020 Cameroonians at the cross-border. And to note that funds for this round campaign were received in country on the 2nd of May, both for WHO and UNICEF. And this partly justifies what you see in the dashboard. And also, just so you know, funds are not sent to the district level, the operational level in Cameroon. The funds are sent from the national to the subnational level, that's the region, that has the payment hub. And from there, once the activities are engaged, the payments are done from the region to the very operational level. And that explains why the moment the funds are at the regional level, they are considered fully transferred to the operational level. And I just would kindly request that you don't feel uncomfortable when our dashboard flows in this line, because that reflects the pace in our country. And of course, any further recommendation to strongly take it and follow up. Thank you so much.
Thank you, Andre. I think we will take the comments down regarding the funds arrival and disbursement to the ground level. I hope Leopold and Ia, you have gotten the comments made by Andrea. Most people are lost on your last part of the comment, Andrea. Can you repeat it, the last part only?
Yes, I noted that when we received funds for this round, for the May round on the 2nd of May in the in-country. And for these funds, Ministry of Health sent the request on the same day to the WHO office. For UNICEF funding, the transactions are done with the delegates of the region, who in this state are filling in and submitting the face and the eyes. And so this does not reflect in the national level dashboard, but rather at the regional level dashboard. And so it explains the variation you see between national level and regional level funding. And so the dashboard really reflects our current context, but we remain available to address any worries. Thank you. Over to you, Stephanie.
Then Lilia.
Thank you, Dr. Sadiq, for the floor. Thank you for the presentation, and thank you also to IM for the excellent presentation for
In the hall,
Nigeria.
mute your microphone, please.
Can you hear me?
Yeah, we call Dr. Dutabe to respond. You are muted, Dr. Dutabe. Your microphone is muted. Okay. While we are waiting for Dr. Dutabe, Lillian, can you go ahead?
Okay, thank you, Dr. Sadiq, for the presentation, and thank you, IM, also for the clear presentation on Nigeria. My contribution is just an observation of the synchronization at the borders. I think Dr. Ndutabe already called out the fact that shift of dates had an impact, but maybe it will come later for discussion. So what also has happened at the borders, we had some support team from Nigeria and also from Niger, is that the synchronization was not so effective. For example, when Nigeria has started, even if the Niger team at the border to meet at a point and do what we call synchronization, the vaccination was not effective since they came with some vaccines and selected some settlements, the case of Maradi and Zender, where they have vaccinated few children and went back until the official date of the campaign. So I think it will be good as we are going forward to also align on strategies. If we are doing synchronization, can you still hear me? There is an echo. Yes. So if we are going to also select borders, district, and LGAs to do the vaccination at the borders, I think it should be also relevant to quickly or to have specific plan where we have a certain number of settlement that we are not just selecting for the launch, but we are also ensuring that the vaccination is ongoing to reach all those border settlements. Thank you. Over.
Okay, thank you very much. It's noted. Nigeria and Niger will respond to that. Dr. Dutabe, is he still there? I could not see him much. Okay, let me take Kasil. He is muted. Karim, let me take Karim. He's a powerful man in the headquarters, so you can't ignore headquarters.
No, I don't think I'm the one. Can you hear me, Sadiq?
Yeah.
Okay, good. Thanks. Thanks for both presenters, IM and Sadiq. My comment is about the first presentation, and thanks, Sadiq. Very honest, straight to the point as usual. Thanks for that. Two comments very quickly. Apologies if this was raised before. My connection here, I think, had issues. I couldn't hear very well, but either now or I mean now or later when we look into the different presentations, if we can understand a bit better what is the issue of the transfer of funds at the country offices. I think we are pushing, except Cameroon, I think this is a very special case, but otherwise, in general, we are really pushing hard from this level to make sure that the money reaches the country offices ahead of time to enable the country teams to distribute funds to the operational level, etc. What is preventing the country offices of both WHO and UNICEF to do that? Is it administration? Is it bureaucracy? Is it so? I hope we can reach some sort of a consensus of some action plan, tackle the issues. Even I don't know. I mean, I know in the past we have talked about sending some operations people during the outbreaks, etc. So if we can understand a bit the situation, I think that would be helpful. Then secondly, you mentioned something to me very extremely critical, Sadiq, the fact that the Lake Chad Basin Task Team is not empowered enough to plan and implement in an efficient way. Also, if it is possible that we unpack that problem a bit better, maybe during these 2 days. The logistics and all that is one point, but I think having someone in the EUC designated by the MOH who can take decisions, who will be accountable, etc., I think that will be critical. So maybe if we can unpack a bit this issue that you mentioned, because I think going forward, if we don't do that, I think we will continue to suffer. Thank you very much.
Bintu, Konate.
Wait, thank you so much. Did you hear me?
Very clear.
Okay, thank you so much. Good morning, good afternoon, everyone. My name is Dr. Konate Bintu for Afro Surveillance Team. Thank you very much for the brilliant presentation. I made to speak in French, which I'm more comfortable, please. Donc, je disais, merci beaucoup, Dr. Sadiq et toute l'équipe. Mon nom, c'est Dr. Konate Bintu de l'équipe de la surveillance polio au niveau du bureau régional. Je voudrais remercier toute l'équipe pour les brillantes présentations. J'ai deux observations. La première porte sur la faiblesse de la surveillance. Je pense que toutes les présentations est ressorti, que ce soit de la coordination de l'ACTIAD ou le Nigeria, par exemple, ça ressort vraiment cette faiblesse de la surveillance des PFA au niveau des pays. Et cela a été démontré avec la notification des virus orphelins. De 2023 à maintenant, la région africaine a notifié environ 173 cas de virus orphelins, dont la majorité, 61%, se trouve dans les pays du bassin de la Tchad, dont le Tchad et le Nigeria. La question que m'avais posée, qu'est-ce qui est fait par les pays avec l'appui de la coordination pour pouvoir renforcer cette surveillance et vraiment minimiser cette notification des virus orphelins? Et ces observations corroborent également avec les revues qu'on a fait dans les pays. Par exemple, au Tchad, en 2024, on a fait la revue de la surveillance intégrée avec une feuille de route bien élaborée qui, malheureusement, n'a pas pu être mise en œuvre dans sa globalité pour des questions de fonds. Le deuxième point, c'est par rapport au niveau GPSAP 2025-2026, qui est la prolongation des anciens GPSAP, où dans les troisième thématique, la question genre est ressortie. Donc, dans les analyses qui ont été présentées, je n'ai vraiment pas vu l'intégration de la question genre qui est très importante. Donc, tous les pays ont été formés sur le niveau GPSAP avec HQ et le niveau bureau régional. Et nous souhaitons vraiment que ces analyses des questions genre intègrent toutes les présentations et toutes les productions qui sont faites au niveau des pays pour pouvoir s'assurer qu'il n'y a pas de biais ou qu'il n'y a pas de freins liés à la question genre qui pourrait impacter les processus d'éradication de la polio et ses sous-dérivés à l'horizon 2029. Merci à vous.
Thank you very much. It's well taken. Both Nigeria and Chad will discuss about the surveillance issues and gaps, as the case may be. And Dr. Toby, then Lara, and then we come back to the audience here. Dr. Toby?
Okay. Merci beaucoup et bonjour encore à tous. Donc, je voudrais juste compléter le docteur Andreas, l'incident manager du Cameroun, avait déjà, dans son intervention, il avait déjà apporté quelques clarifications sur la disponibilité des fonds au niveau du Cameroun pour le round 2. Donc, il faut dire qu'au niveau du Cameroun, les fonds ont été reçus au niveau du pays depuis le 2 mai. Donc, ça fait bientôt 2 semaines. Et nous sommes dans le processus pour le transfert des fonds, donc au niveau du ministère de la Santé et au niveau des régions, aussi bien pour l'OMS que l'UNICEF. Donc, ce qui est au niveau du dashboard pour la partie nationale reflète bien la réalité qui est sur le terrain actuellement. Alors, il ne reste que le transfert des fonds au niveau régional Il faut dire que le Cameroun implémente pratiquement depuis plus de 4 ans maintenant le paiement numérique à travers Comcare. Donc les fonds ne sont pas directement transférés donc, au niveau mais c'est transféré au niveau des plateformes qui sont au niveau régional et au niveau des districts. Donc c'est ce qui se fait. Donc les gens ne reçoivent pas directement l'argent, donc on frais avant la campagne. Donc le paiement se fait, numérique se fait pour les différents acteurs, aussi bien les acteurs au niveau, les acteurs au niveau de première ligne sont payés, ainsi que tous les superviseurs, donc juste après la campagne, à travers la plateforme numérique comme Care. Donc, pendant les préparations, lorsque les questions sont posées aux acteurs au niveau opérationnel, disent qu'ils n'ont pas reçu les fonds. Donc, c'est parce que c'est ce paiement numérique qui est mis en place à travers Comcare, donc ce qui ne reflète pas vraiment la réalité donc, au niveau du Cameroun. Ce sont ces précisions que je voudrais apporter. Sinon, pour ce qui concerne la disponibilité des fonds au niveau opérationnel, cela n'entrave pas donc, le démarrage et la mise en œuvre des activités donc, en pré-campagne. Comme pour le côté de l'UNICEF, les fonds sont transférés directement au niveau des régions, au niveau opérationnel, au niveau des régions et au niveau central pour la coordination centrale. Donc, voilà un peu les points que je voudrais donner. Et nous sommes dans le processus pour le transfert des fonds et nous espérons d'ici le lundi prochain, les fonds seront disponibles
And we hope that Monday next week you will receive
au
them.
niveau des régions et au niveau central, aussi bien pour l'OMS que pour l'UNICEF. Merci beaucoup à vous.
There's an echo in the room again. Sorry, Dr. Sadiq, there's such a large echo that we can't hear online.
Okay. They are not hearing us.
We can hear you, but there's a lot of echoing. So I can't even hear myself.
Okay.
Oh. Okay, now it might be better.
Okay. So they said they will be sorting it out just
Okay.
with what you have said.
But I think I can hear you now. You can hear me?
5/5.
Yes. You can hear me? Sorry.
We hear you loud and clear.
Okay.
5/5.
Okay. Great. Okay. So, no, thank you very much. I just want to echo the appreciation for the frank and the open and the honest presentations and conversation that's already been had. I just wanted to echo and amplify Sade's point. And we've already heard, Nigeria's proposal to consider shifting the campaign launch to June 14th. And so now as we hear from the other countries' presentations, we're already starting to hear some of the challenges in terms of funds for round 2, and knowing that, we would be looking at a launch of a campaign in 2 weeks. And, basic activities like funds transfer are not there 2 weeks before the campaign launch. It's really critical that we sit here today and rigorously assess each country's readiness to launch within that 2-week time frame, because a campaign proceeding for the sake of just proceeding is not a good one. We really have to focus on delivering with quality, because otherwise we risk undermining the very objectives we're aiming to achieve in this critical region. So we all know that we have large resource constraints. We're all facing it, and so we need to really be very measured in the approach to make sure that the solid foundation is there, addressing some critical gaps and quickly, and ensuring that each context and each country is considered and prepared. So I really strongly support that suggestion to structure the review topic by topic and country and block, so that we can have a very clear path forward of these challenges and then make a very good evidence-based decision. So just to, again, amplify that point. Thank you. Over to you. We've lost the audio in the room. If you are speaking, we cannot hear the meeting room. It looks like it's muted.
They are not hearing me again.
Okay, can hear you now.
Okay, good. So let me just take from Kasil. There are advisory. Yes, Kasil, can you go ahead? Kasil? Okay, we'll come back to him. Let me go to Chris. Advisory.
Yeah. I mean, look, to me, there are many, many issues that have been raised that we will discuss, I'm sure, over the next few days, but especially tomorrow. One thing that strikes me a lot from your first presentation is that we need to be, as much as we can, looking at the most recent data that we have, and I think that we're missing that a little bit, and that I think is going to good topic for us to discuss tomorrow when we look at the coordination group and the things that are happening. I noticed that for Nigeria, for example, we have bits of data, pieces of information that don't seem to align very well with each other. Some which is very encouraging, some which is very worrying, and that they don't necessarily seem to be a consistency in the information that we're looking at. And I think that this may be one of the ways perhaps that the Lake Chad Basin Coordination Team can help and support is by trying to look at this enormous amount of information that the Nigerian program has and see what can be aligned and what is strange and needs to be investigated. That's enough for now, because I think we'll be talking about this a lot later.
Thank you. Well noted.
Thank you very much for the two presentations. For me, I'm very, very concerned about the whole situation, both at the Lake Chad Basin coordination, but as well as in Nigeria as well. I'll not go into much detail, but what makes me very concerned is when we look at the numbers of cases, when we're saying 12 months ago, 9 months ago, 6 months ago. Ladies and gentlemen, 6 months ago, we are talking of the low transmission period. But when we look at how geographically these cases are being reported, we still have a lot of work which have to be done very, very quickly, because these are not restricted to few areas where we can say we're going to knock out this transmission before the end of the year. So my concern is that there is a lot of work needs to be done. And we really need to really come out after these 2 days. What has to change? Because the same status quo is not going to take us anywhere. So it has to be really drastic things have been put in place, both at the country levels and Lake Chad Basin coordination, for us to make some really gains on where we're going. And I really agree somehow to what Lala talked about, that I think now it's not a matter of just doing rounds because we just want to do rounds. I think we really need to see what can be really put in place, both at Lake Chad Basin as well as in the countries, for us to make some progress. But the way the things are going now, it's like laissez-faire, business as usual. I don't think that we're going to take us anywhere before the end of this year. Thank you very much. But as my friend Chris said, I think this will be discussed more tomorrow. But it needs a really revamp of this situation, both at the Chad Basin as well in the countries. Thank you.
Thank you. I think yes, Dr. Yeah.
Thank you, Dr. Sadiq, and thank you for all the presentations. And I think this meeting provided a very good opportunity for interaction. So I want to congratulate those who thought about this and bring us together to do this kind of a review. And one thing again, in your presentation, Sadiq, you have mentioned that the ministers of this region met in Chad, and they have also agreed to do what we're supposed to do and do it properly. I wonder if this report of what has happened for this round is going to be transmitted to all the ministers that participated or send their representative, because they came in and they have a signature that they have all committed to doing what they're supposed to do. So my expectation, my recommendation to the Lake Chad Basin team is to send them the feedback of round after round, activity after activity, so that they will be able to be carried along. They know what exactly was happening. The second aspect of it is to all the presentations where you have the missed settlements. The missed settlements, some places are huge, and then we cover under many things. So for us, can we delineate to see which one that they are in our records, we are not able to reach them? Is it lack of teams? Which one that is because of security reason that we are not able to reach them? So that we know we segregate the ones that the program is not able to reach for whatever reasons, because lack of teams or lack of whatever reason, but this one is for security reasons. This is my second. And then the part of it again, and Lake Chad, I mean the Chad issue. I think there's multiple problems that we saw in Chad. So I wonder if there is going to be a convening in the Chad in N'Djamena to look at what can we jointly help this country to get to where they're supposed to go. If within the capital of N'Djamena there's the kind of a huge problem. So I think there's completely a big challenge within that. Is it a human resource challenge? Is it a planning challenge? Is it too much activities on them? So I think the Afro is sitting there. They have the country office. What can we do in order to help Chad to get to where they're supposed to be? And I think my last one is that I heard that there's a early release of the global funding to countries of the Lake Chad Basin, but releasing the money from the country office to the countries is where you have the delays and going to the provinces of the LGS. So what can we do? I hear referring some kind of budget back and forth. What is the mechanism that the Lake Chad Basin is setting up to make sure that those kind of bottlenecks that have happened before should never happen again? If a technical need for support or whatever templates are supposed to be used, we should use it quickly and to get onto that one. And again, the last one is to what you have said, that Nigeria is not reporting on your own dashboard. What is the reason why Nigeria is not reporting on your dashboard? Is there something that we can talk about with Nigerians that are here? How can we make sure that all of us are reporting? If other countries are reporting, Nigeria is not reporting, why are we not reporting on your own dashboard? Thank you very much.
Thank you. Okay. I think once we take Patricia and Kasil, we can allow Nigeria to respond.
So thank you very much to all the presenters. Like everybody says, great efforts, good job. The overview from the Lake Chad Basin Secretariat Committee, a few things came out strongly, but I will not revisit those that have already been mentioned. I look at the LQAS performance in Chad, in Central African Republic. They were really woeful. And I know we will listen to them, their presentation soon. And I'm hopeful that we'll hear what the real big challenges are and what plans they have. For Cameroon, I was wondering how you measure reach in the northwest and southwest regions of that country. I have an idea that there are security issues, but so how do you measure reach? I like that Nigeria laid it all out. They have had a chance to, and probably because we have had a chance to listen to Nigeria, what worked well, what are the specific things they did to try to improve the campaign quality, and from their lessons learned, Nigeria has made an informed decision to move their dates for better planning. So like somebody and many others have said, what would these other countries, what are they thinking about, especially given the last campaigns and that 2 weeks to campaign time? We are still very far off. I will stop here as my other observations have already been taken up. Thank you.
Thank you. Kasil, are you there?
Yeah, can you hear me?
Yes, go ahead.
Okay, thank you, Dr. Sadiq, for the quality of your presentation. Sorry, I'm fighting with my mic. Some of my observations for the country like Chad, I will keep them when the country will present. But regarding Nigeria especially, my first suggestion is what you raised regarding the preparedness activities or dashboard. I feel Nigeria developed the tools. And because I was there and I supported Sokoto, they have tools and some indicator to assess preparedness. For me, we need maybe to agree on two options. The first one is if the country can provide or give access to our data manager to access to the platform, maybe we can also see how to collect some of these key indicators for preparedness. The second thing is, as coordination, maybe we can agree on some key indicator for the country to report during preparedness activities. The second is the issue regarding the no compliance. And what I suggest is to take advantage in between campaign. How can we take advantage with all those CSO, the no compliance resolution team we deploy? How we can strengthen their activity in between campaign and to report what we are facing as challenge to different stakeholders. We got a key commitment from Sultana, Emir, all those things. We don't just go to share with them our challenge just 2 or 3 days before the campaign. Even in between campaign, all those challenges we are facing for all no compliance, I think we need also to see how we can report and to see how they can continue to give the support. The last point is the question regarding the EOC meeting period of campaign. Maybe the IM can see how to put a mechanism to monitor, because what has, for example, in Sokoto, we started this EOC meeting, the D1. But if we need to monitor and to track the quality of the campaign, we need to start maybe at least 5 days and focusing on those preparedness indicators to ensure that we can improve the quality of our campaign. Thank you. Back to you.
Abdul Kadir, the MIM for Nigeria to respond to the issues first, then maybe where the questions are directed to like Chad or other we will take it. For countries that have not presented yet, such as Niger, Chad, where issues were raised, please, the rapporteurs will remind us when they presented so that we'll we'll go through the issues and the questions again. Thank you, because their presentation might address some of this, so let us give them the opportunity. Dr. Abdulkader.
Okay, thank you. I think the questions that I had, maybe if I didn't get all, maybe you remind me, but how about the dashboard? I'm surprised that Nigeria is not reporting the dashboard. That may not be correct, because I know we start with our team in Nigeria, start with the Afro team, Caroline, who was here. We've agreed on what to do, and we are reporting. So I'm surprised that, so I think maybe the team really has to go back and ensure that that works. We considered a team, just like what Cloud said. Cloud was here, he was part of them. So I'm surprised that we are not reporting. So there's something wrong somewhere, but I don't know where. But I knew we worked closely with the Afro team to ensure that we report this. We had issues, and that was resolved by our team and then the Afro team. Caroline was in Nigeria for quite some time, and she worked on that with our team. So I'm really surprised that maybe if we need to reach out to Caroline to find out where the issue is. But for that, I'm sure we've done a lot of work on that, and then we think that has been resolved. I'm surprised to hear this at this meeting. Don't happy for that. I think Cloud talked about non-compliances. Yes, the traditionally have really, committed themselves to this. So what we do for non-compliance is, as the campaign is on, if you have issues, we have non-compliance resolution team who helps to, resolve. We also have line lists of non-compliance after the campaigns that are usually submitted to the NTLC to ensure that they resolve. So it's something that is continuous. So for us, it's something that is currently working. And then the CSO also helping in resolving non-compliances. And in the April campaign, they really resolved over 25% of the non-compliances. So for us, it's a continuous exercise. And we all know non-compliance is not something that you can resolve 100% in one campaign or intra-campaign. But we've given ourselves like 2 weeks after the campaign for most of this to be resolved. So a line list, already you have a line list, and this has been submitted to the non-compliant resolution teams and then the NTLC to continue resolving them. I think this is what I have for Nigeria. I don't think, are there other questions? Okay.
Dr. Abdulkader, the other thing is about whether you will be able to talk to Sokoto or somewhere. The EOC to commence much earlier. Yes, the EOC meetings, I think at subnational. Yes, at subnational level. And then let me just see, the other issue is related to the GPI coordinators who can answer that, why there are funding delays within UNICEF and WHO system. And we have Dr. Kofi here for Nigeria, which is a blessing. The other issue that was raised by Dr. Bintu is about orphan viruses in Nigeria and Chad. So for Nigeria to respond, what are they really doing to avoid the future occurrence of orphan viruses? This is another thing. I think the other issue, which is a general that was thrown across and the other countries have to decide on that, is whether we should consider the timeline that we have set for this round. Nigeria has already shown they are moving forward the dates, so they will get more ample time for preparation. Will other countries consider that? And then the other issue that was raised by Chris Meyer relating to Nigeria was some of the variables that have been shown on the data that you have presented, they are not consistently aligned. In one area, they look superb. On the other area, they have not looked, they are not consistent with the other results. For instance, for me, which I picked, if I want to give an example, is routine immunization. and IPv2 coverages and the viruses that are occurring. It seems, if though former Sokoto State, Sokoto, Kebbi, Zamfara seems not to be doing, they have less than 15%, as you have said. But if you look at also the IPv coverage, they of some of the states, they are at 50-something, 60-something. I don't remember them, but Benue, some states in the northeast, they are doing, even Katsina, I think they are around 50 or 55, Katsina state. So we are wondering that why are we having all this with they are passing LQS, they are having increasing improvement in the coverages, and at the same time they are transmitting the virus. I'm not saying that's what Chris has said. I said what I have seen. Just one example to give. And then I think these are the things. So for Nigeria, I think the coffee will help us to explain what are the bottlenecks in the transfer of funds from country office here locally, while Dr. you'll address the others.
Yeah, thank you. Thank you very much, Dr. Sadiq, and good afternoon. I think, to be honest, we did not have any challenge with funds transfers for this campaign. Almost all the funds were there 2 weeks before implementation. In terms of operations, honestly, there was only one element which has to do with the Indomie component, which we needed to procure and make sure it happened. But it's just that the request was very late. Otherwise, we did not have issues with operational funding challenges in the states. I think that's all from my side. I think you've also highlighted, maybe I'll share some comments around orphan viruses. It's very concerning, but the other side is that we try to prioritize in those high-risk LGEs bordering Niger, Yobe, Katsina, Jigawa, and the rest. Try to review the network of community informants. So if you look at the data, you see that we actually increased the number of community informants because previously we knew we're having that challenge. It increased the number of detections of orphan viruses. We've done the investigations and realized that there are some issues around active case search, committee engagement, and all those issues there that we have prioritized through the surveillance improvement activities for those states. And we are closely monitoring that. But on top of that, what we also note in the detailed investigation is that we also need to address some of the immunity gaps in those areas, particularly for type 2. And I think the Oversight Committee would have to help us to advance the conversation around rolling out the in-between round activities in targeted populations. As we all know, these are very fluid populations. I can speak to the VPV3. Oh, sorry, okay. I can speak to the VPV3, for example. And if you look at the trends from Nguru, in Yobe down to Damaturu, there are big markets across. And you have a lot of population movement across. Now, the case that was we isolated, detected VPV3, apparently has spastic paralysis. So actually, you realize it was coincidental. But all the contacts also had the virus. So our question, how would we have detected type 3 if we had been classical about, assuming somebody had done a detailed investigation and realized that, okay, this is spastic, so it's not, refused to take the sample. So the conversation about healthy children sample in priority areas where we have, for example, silent wards that are clustering. These issues we have to also take, and it comes with the laboratory logistics requirement. And yet we are talking about decline of funds. So we need to help us to prioritize. How do we manage that? For me, if you ask me, what I've asked the team to do is to help us prioritize those high-risk wards, which ones have remained silent, and how do we monitor through healthy children sample to assess whether we have any risk ongoing there. So I think I will stop here for now on those, and then Dr. Abdulkader.
Okay, so I think Dr. Gobi has spoken much about the orphan viruses, so that I'm taking care of. So the issue about routine immunization. Okay, so you talked about routine immunization and discrepancies. Well, we'll look at the data, but this is what we have, and this was supplied to us by our RI team. But still want to put on record, still we want to maintain this stand. The same areas where we have low routine coverage are the same areas where we're having more of the viruses. So we still want to maintain that as a country. That's a trend we've seen, and that is what we're seeing. We also need to strengthen our, no matter the variation in what you talked about, the routine immunization is not optimal. And where we're having the burden of the virus currently are in the same areas where, so we as a country, we still want to maintain that position. Thank you.
Thank you. So we finished Nigeria. We finished with Nigeria.
Thank you, Sadiq. I'm Asuna Kosaga. I'm from UNICEF. Can you hear me? Can you hear me or no? You can hear me, yeah? You can hear me?
Yeah, we can hear you. It's perfect, Asna.
Thank you. I want to comment on two areas. I think for funding, at least for April round, we have not heard any complaint, at least on our side, that funds have been delayed. Funds have reached the sub-national level on time. Therefore, I don't remember any. On non-compliance or refusal or what you call it, everything, of course there are and there are some increments, maybe with improvement in the documentation. But when we analyzed the data down, the main reasons for missed children are child absent and then compliances. And most of the non-compliances have been addressed through different mechanisms. As I am said, through the non-compliance resolution team, which we increased significantly during the April round, all over in the northern states, from 271 teams to about 1,514 teams. This was very significant. As it was also presented as one of strategy shift, we engaged also CSOs. And these are not the only one to address the non-compliances, but also every facilitator, every supervisor have tried to address. But still we have some unaddressed non-compliances. But I want really all of us to see the whole picture. Non-compliances plus child absent, when we see in comparison to the target population, it is less than 1% of the target population. Is this non-compliance that which is keeping the immunity level low and our ongoing transmission? I don't think so, because it is very low number. There must be something which maybe we are not documenting, undocumented non-compliance maybe, or undocumented child absences or not visited houses, I think. Otherwise, the documented, when we see the epidemiology, the documented child absent and the documented non-compliances are very low. And 1% of unreached children, I don't think is going to keep the transmission going on. Therefore, I hope the team will see this data in deep and maybe find out something, because it is external eye, which you are going to see. Thank you so much.
Okay, thank you, colleagues. I think we have discussed, and we still have thematic areas tomorrow to discuss in detail. Let me just quickly say that for the questions relating to the issues of transfers, we believe that the incident manager and the GPI coordinators of the respective countries, as they make the presentations, I'm talking about Niger, CAR, and Chad, they can address it in their presentation. While issues relating to empowering the lecture coordination, we have taken note, and it will be discussed in detail tomorrow under the thematic areas. Niger also will respond to how they are dealing with the orphan virus, Niger and Chad, in their presentations as it comes. Regarding to the delay, I will advise the advisory committee. How can you advise the advisor? Let me refresh the language. Regarding the change of dates, I think what we need to do as a group, because tomorrow they may not be here, let us have it as one of the key points that each country should say exactly where they stand regarding readjusting the timelines that will provide them sufficient time to do the activity. Because tomorrow the GPI coordinator and incident managers, they are not part of the meeting. So we need to get the response today. So I will urge all the other countries that have not presented, please cover it in your presentation to say the position of the government or the IMS system there regarding readjusting the dates. For example, just as a devil advocate, although I'm not a devil, is that if Nigeria is shifting the campaign to the 14th, what will Niger do? Is Niger going to align the dates, or is Nigeria going to vaccinate the border when Niger is vaccinating? Let's say, assuming Niger is not moving to the 14th and they are keeping it on the first week of June, of June, what are they going to do? Are they going to, Nigeria moving to say the borders will cover it with you if you are vaccinated between 1st and 4th of June? Or are they going to, now that is Nigeria will join Niger if Nigeria maintains the date as it is? Or is Niger going to, how do we synchronize? That is just not for response now. It's for us to have a clear understanding of what we are going to do forward our borders. In the same vein, Cameroon is going to have a date as it is. That is by 30th, they are going to the field. 29th, 30th. Nigeria is going to start on the 14th. What happens to the villages and towns along the border of Cameroon and Nigeria between the two countries? This is just for discussions. So I think these countries, as they are presenting, Nigeria has already initiated the process. They said they are likely to move the dates, and therefore we need to now, the remaining countries, hear from them. Regarding the feedback that Dr. Iya said, we'll cover it in our next bulletin. Fernanda, Katarina will handle it, and we will share it with the ministers of health regarding the performance of their countries. Disaggregating the settlements that are not missed, please, countries should be clear in their presentation to say whether settlements were not reached due to A, B, C, D. If I want to give example with Chad, in Jamena province, most of the settlements are accessible in terms of terrain. What we have is excessive workload on some teams, and where some teams even vaccinate more than 600 per day. So I think it's an issue of teams, not an issue of security, not an issue of geographical accessibility. So, but we will hear it more from the incident manager as he is going. Regarding mechanism to address delay of funds, this will be discussed in detail tomorrow. And why Nigeria is not using the dashboard, Mike Mwanza is here. I think he will link up with Caroline, and then we will understand the issues around it. And I will also call on the incident manager that the second alternative given by Kasil is that if you can share the link, is also another shortcut to the solving of the problem, because as it is, we do not have the link or to go to the dashboard, the actual dashboard. The actual link shared by Mike is always not providing that information. So maybe they can harmonize on that and then look at variables, the minimum number of variables that should be on both dashboard for comparison between countries, so that we will have similar variables that we will look across the Lake Chad Basin on that. So Mike Mwanza and his team, Torre, please take note of that. On that, I'm also a big man. Can you imagine? I just called his name, he shook his head. So please, let's look at it. The non-compliance, I think, has been addressed by the incident manager. Unless there are other burning issues, I think these are the things that we have that is pending, Dr. Abdulkadir.
Okay, thank you. So I think we've went back and forth about this. Even the issue of link, we've shared the link with the Afro team about, so I'm surprised, but we'll still go back and see what but I think you need to discuss with your Caroline, because she was in country when all these things happened. Then I think the issue about our June campaign, I heard you saying maybe. We've shifted. There's nothing like maybe. As a country, we've moved. It's 14 June, so it's not we may. Thank you.
We will reflect that.
On the same thing of the dates, I think I just want to say that it should not look like we're putting the other countries on the spot to shift the dates because Nigeria wants to shift the dates. I think that's a big tall order on the countries. They may not have another answer here for them to change that. The issue is that even before we heard from Nigeria, when we had the Lake Chad Basin presentation, the challenges are just too many. This date, or 29 weeks from now, cannot have a very good campaign from all the countries. You sure that said, Dr. Sadiq? Cameroon, 0, no planning, 0, no micro. No. I mean, how can they have a campaign 2 weeks from now with the dashboards which you have at Lake Chad Basin? So let's not push here that this country should align with Nigeria. No, I think that's the wrong message. The issue is that the countries cannot do a good campaign, as I mentioned earlier, looking that you still have widespread transmission during the raw transmission period. The reality here is Nigeria or no Nigeria, the dates have to shift so that people can do a good campaign. Thank you.
So the take-home message is that we should not jettison quality for the sake of synchronization. So we should be very, very clear that this is our last hope before the high peak of the transmission period, and therefore we need to do the right thing appropriately. Dr. Akif?
Yeah, thank you. About the dashboard, because we are monitoring it at the regional level on daily basis. We have daily morning briefings. Sadiq, you are also attending that one. So 0 does not necessarily mean 0. Sometimes the countries don't really update, don't enter the data. So that's when we see any sort of that kind of below threshold, not only 0. So if it is below threshold, according to the dates to campaign, we immediately alert the block facilitators to get in touch with the country's GPEI coordinators to check it out, whether it is the real situation, real time, or because they are not entering in data for so many reasons. Sometimes they complain about because this is an online tool, the internet or busy schedule, something like that. So that's what I'm trying to say. It may be, but it may not be. So usually we deep dive and look what is the real situation on the ground to understand really the preparedness levels. Thank you.
Thank you very much. Let's give Nigeria and the presenters a big round of applause. I didn't hear it all. Very good. Thank you. So let's go to the presentation for Niger Republic. Sir? It's lunch. Let me ask whether the food is ready. Chairman Lee, can you ask whether the food is ready? find whether they have already arranged it. Because usually they'll tell us if it is ready.
It also coming. That's another reality. Especially, in June. Early June. In countries like Niger.
Yes. Please, also another issue for those that are online, Nigeria, Niger, Chad, maybe parts of Cameroon, I don't know, but at least this, the Eid prayer for the festival, the Eid festival will be somewhere within week one, somewhere in the first week or second week of June. Early part of it, between 6 to 8, there will be Eid prayer around that, before 10th. So we should also be very careful of spilling our dates into that area when we are taking decisions on that. So the food is ready. We will no. A week before the campaign, it's very complicated because after as well. So please, the launch is which room? Did they tell you? Which room? The launch. Open. Ugu. Ugu Nongo. Okay, Ubudu. You have the ticket. The master of ceremony, no ticket. Eh? So let's go.
Dr. Sadiq, what time will we start?
No.
What time will we resume?
Please, we need to finish in 45 minutes. We are a small group. Yes, 45 minutes, we come back here. Okay? Please, let's go. Obudu. And who is in charge of this room in the hotel? Security. If you don't see me, don't allow anybody. Yes. Until I come. 100%. All of them are hearing. Don't be afraid. Yes. If anybody coming back before me, he stays outside and make telephone. Good. Thank you.
Thank you.